Good morning, everybody. Welcome to the second day of the 10th anniversary meeting of MiECTiS. To open this perfusionist session, we have Hans Jenny, clinical perfusionist at the University Hospital of Bern, and he will be discussing minimized circuits, optimized perfusion strategies this morning. So the floor is yours.
Thank you very much. Dear Chairman, ladies and gentlemen, dear friends, it's a big honor also to open the day. Yesterday I had also the honor to open the session. I do it the second time now. I feel pleased. So I will talk about the modern perfusion strategy, not just about circuits, about the modern strategy, how we have to perfuse patients. Of course, one really important component is the system, and the system has to be maximal biocompatible. That is a fact, yeah. And then suction blood management, of course, and then I will also a bit focus on the safety strategy. It's also important to have an effective safety strategy for the perfusion strategy, and as well, we have to perfuse. We call that in Bern patient-adapted perfusion. So we really have to adapt our perfusion to the patient, or we can also call that individualized perfusion strategy. And on the end, data collection and data analysis. That's a big part of new perfusion, also to give a clip into the future and to get new parameters perhaps one day. It's quite clear we have to reduce the inflammatory response. That's quite new. It is quite known, but we have different actions what we can do. Of course, we can shortening the tube. We can also minimize the surface. But what we heard yesterday as well, we often discuss about the reduced cardiac index. So we say in mini bypass, for example, we can reduce our cardiac index to 2, for example. I don't know exactly how high we did in Bern as we did MEC, between 1.8 and 2. What that says to us, we do not need any more so big oxygenators, for example, because if you look here for Terumo, we have the Terumo FX15. The Terumo FX15 has a maximum flow of 5 liters. And with 5 liters and the index of 2, you can perfuse 90% of all European people. Plus other countries are a bit heavier, but normally in Europe, 90% of the patient you can provide with a FX15 instead, for example, of a FX25. And what that means for us, yesterday, Mark van really told that the biggest surface is the venous reservoir, but also the oxygenator. If you compare that, then you have a difference in the membrane surface of 1 square meter. That makes the surface in 34 meters of 3/8 tubing. You can economize just to use a different oxygenator. On the other hand, we have to minimize priming volume. That's clear. We all know that. We also have to think about the impact on DO2, because I go to the preoperative approaches. I think DO2 therapy starts based in the general doctor. It starts 2 or 3 weeks before the patient come into the OR. I will show you an example later. So that's really important, and we can discuss in a group that patients will not come with low hemoglobin into the race. On RAP is, of course, we have to practice RAP. That is not a question. I give you an example from a patient, a mitral valve redo, patient with 90 kilos, 1 meter and 80 centimeters. He comes in a race with a hemoglobin of 9 gram per deciliter, PO2 200 on the machine, saturation is clear. So if we have a flow from 5 liters, this patient has a DO2 index of 306, and we feel comfortable. What if during the case, the patient, for example, blood loss, and then the hemoglobin decreases to 7. I calculated now this patient has a DO2 index from 241. So he has a higher risk for acute injury. What can I do? So I have 2 actions to do. I can increase the flow, or I can add red cells. So I calculated if I want to achieve with a hemoglobin from 7 for this patient and a DO2 from more than 285, I have to increase the flow to 5.9. I forgot to mention this patient is cannulated femorally with F25 from Biomedicus. Now the point is, if I have a cannula of 25 French in this patient, I will never be able to increase the flow to 5.9. So I'm really a bit trapped, as a perfusionist. It sounds always easy. You could just increase the flow, but I have no option to increase the flow. If you look here on the flow chart from this cannula, That is a bit the problem, and that's why I said if the patients, they come, DO2 starts earlier. DO2 gives us not so much opportunity during a perfusion as we expect. And on the other hand, we also, a hospital we teach, I tell always on my students, okay, now we have a situation, your DO2 is perhaps lower, but that will not mean that your patient now will make a kidney injury. This patient has a higher risk now. You can imagine on your screen, then you have a blinking parameter. Oh, this parameter is now in a red or something like that. So that means he has a higher risk, but sometimes we have to accept, because the other option will be this patient get red cells. And we all know red cells, that is really a high risk for acute injury. So the only thing we can do, and that is a problem a bit nowadays, we do not have so much opportunities. For example, I go to jump a bit back, is as an old perfusionist, you know, we have it in the back, so we will cool down, for example, the patient. That's the reaction we did in the past. But the other hand is also how we can react on low DO2. Perhaps what's the role of the pressure? You know, we have no idea between DO2, and perhaps we can, if we are not able to increase the DO2, perhaps we can increase the pressure. So it has a lack of data. Okay. Sorry. And of course, we have to minimize the blood-air contact. That's also new. But here I have a bit provocative question, you know, or perhaps someone can answer me this question for the audience then after. Is there a certain amount of blood-air contact when we can accept, for example, or tolerate, you know, because that will easier our life massively, you know, because we really try to avoid 100% the blood-air contact. I fully understand, but is there a limit of blood-air contact that we can accept? Because we can make the systems quite easier if we will do that. It's just a question to the audience. And if we go back and we see which systems fits best with all these requirements, that's of course is the MiECTiS systems, sure. And there are best for that. Yes, best will be type 4, that's for sure. But even in type 4, you have to deal with the vent blood. And that is the point that often clinics, they are a bit afraid about mini bypass type 4, because the suction blood management becomes key then. And I just show you this slide because there's some open question. If you use a mini bypass system and you separate the suction blood, then at which amount, where's the threshold to give the blood back into the system? You know, you take do like a certain amount of blood you take out of the systems, for example, 1 liter. But when do you have to reinfuse it, and which amount you can wash without harming the hemostasis? That's a central question, and that I have no answer for that. But perhaps you have to make some tests intraoperatively before we give back. That's one. But the one point is really important. The suction blood must always be in the view of the perfusionist, because I always have an idea how much blood is outside of the patient. That is really important, not just to use a cell saver. I really recommend to use a separate reservoir, and then you can give it back, but you must have the suction blood in the view, because then you can decide to give it back or not. So what we do in Bern, and what we start to do in Bern, is as I mentioned yesterday, we had a bit of problem. We stopped the MiECC program. We go direction optimize ECC, and perhaps I hope one day we will jump again into a mini bypass or MiECC. What we do for the moment, that we will try to work with this new reservoir from Spectrum. That offers, I think, interesting things, because they have this closed chamber, which is a membrane into it looks like a ball, that offers you to be quite closed for cabbage. And we can also not open it, but we can then have the opportunity to work as a double chamber reservoir. That means you have the chance to make a differentiation between good and bad blood. I call it always good, bad blood. The blue, also the main sucker, that's bad blood, and vent blood is quite good blood, you know. Then you can separate that. That is one option, that what they offer here with this new reservoir. I'm sure they will penetrate the market in the next months, and let's check that. It's really interesting thing. And another big advantage that is, even if you have a membrane in a ball, you have the chance to use VAVD. So that's the difference between the old systems from which were used often in the Netherlands. they had to put a second rotary pump to suck. So that's not the case here. You can really traditionally use vacuum. The other point is, really one of my favorites, is real-time monitoring nowadays, and that becomes important. And why real-time monitoring? Because real-time monitoring, that's an online quality check, you know. You see immediately what you're doing. That's one point. And on the other hand, it makes perfusion visible, you know. As I started perfusion in the past, we are all hidden behind the machine. Nobody knew what we're doing. And if someone came to us and asked, we say, okay, do your job, I do my job. And that completely changed now with online monitoring. We are visible for everybody. We also discuss with the anesthesiologist and also with the surgeon if something happened. We are not hidden behind the machine. That's one point. And the other is, we are a training hospital. You know, if I have young perfusionists behind the machine, I just jump in the theater and you see quickly what happened. So, and everybody see that. That is important thing. And the other point is as well, to be honest, I don't know, in Switzerland, we have really a lack of skilled person. It's quite hard to find experienced perfusionists nowadays. So we have to think about that and to make the circuits more safe, because the niveau from the perfusionist will not be the same, I'm absolutely sure, in the future, because we have a lack of person we can recruit for this profession. And on the other hand, this real-time monitoring allows us the implementation of new parameters into the clinical routine. And as well, if you have online monitoring, you have to be aware, because as I started, we have some manual notices, all the protocols, and then now that changed completely. Now everything is automated. Put alerts in, because that really increased the safety as well into the overall, as pilots are doing. You know, every parameter has to put an alert in. That helped really. Also, as we started with automatic data registration, I felt a bit lost a bit, because I couldn't have the opportunity to make notices about the blood pressure, for example. And then sometimes if the blood pressure decreases, I didn't realize it. So that's why I speak from my side, you know, I know that. So that's really important to put alerts in. And then also that will be published from my angle. Just to give you an idea about monitoring. Monitoring has not also been to be very, very complicated. There are easy parameters to measure. They're really implemented now, the venous flow. Nobody measured the venous flow in the past. We have just had this, we measured just our arterial flow. But that can really be a safety tool to measure a venous flow. There's two aspects, for example. During cerebral perfusion, you know exactly what comes back from the brain. So you can really avoid stasis in the brain. And the other point is, you remember all the discussion in the OR. You have the backflow is, I know, and you have bad backflow. You tell the surgeon, I did nothing, you know, nobody did nothing, you know. But you have, in fact, you have a bad backflow. So if you can measure it and you can show, you can say, okay, take a look here, my backflow is reduced. That's a fact. And it's also in the protocol after. Then you can also start to discuss differently. It's not a question about I did nothing, just it's your problem and so on. The fact is the backflow is reduced. And on the other hand, you can also detect bubbles that come from the venous side. Ignacio discussed it yesterday, so you can also avoid, you can tell the surgeon if you have bubbles that come from the venous side to do something. And you can also it's not just a story for me, it's reality. We measure bubbles that come back from the venous side. Again, how to perfuse, so that will take too much time. I'll just give you two or three messages. Of course, the BSA based as a basis for perfusion, that's give you a rough point of reference. Of course, everybody starts with the 2.4, but then you have to adapt the perfusion as we do nowadays. And we have now so good parameters. Yeah? We can guide our perfusion. Okay, SVO2 is the old one, but we have cerebral SO2, we have the DO2, we have extraction rate like that, and perhaps for the fusion, a VCO2, that was also interesting parameter will come if we are able to measure it accurately. That is a bit the problem for the moment, but we have so much things that come in that make our profession really, really challenging and interesting again, you know. And The challenge, as I mentioned, is that the correct interpretation of the parameters, that can also be challenging. You know, we have so much parameters, and our topic for the future will then be to bring them in link them together. And then not forget, we have to see the whole picture, not to be focused on one parameter. As so often perfusionists that are just fixed on this 280 milliliters of DO2. That's just the same story as we did in the past with a strict flow. And on the other hand, I hurry. Sorry. On the other hand, I also wish for me to have in the future a bit more time response-based recommendation. I will show you what that means. So I will switch here. You have two approaches for TO2, for example. But an interesting publication from Japan was what they measured was the time under a certain curve, not just to be lower, because how often we see that the pressure is lower than 50, for example, for a patient. But that will not harm the patient. The question will be, how long was it under this curve? And that I'm absolutely sure that will be future. And I hope that artificial intelligence will help us to analyze data, that you can give this recommendation one day. Shortly, an overview about what we measure in our clinic, automated. So we have all the parameters here during a case. That's transparent for everybody. And we can see, I can also see that from home on my phone if I will. So that's clear. And now we have to start to analyze this data to bring them in a context. And hopefully we'll also get then some recommendation about time under a curve. Now I can conclude that, to be honest, optimized perfusion are a result of MiECC, and I really hope then we go as well further. And then if you start with optimum ECC, one day you will find a minimized bypass in your clinic, but starting with optimum ECC is never bad. Modern perfusion strategy include more than a perfect perfusion system. Of course, that's real-time monitoring, patient-guided perfusion, data record systems that are equally important as the system itself. Correct data analysis and data collection enable a better interpretation of key parameters. Time dose response-based recommendations may play an important role in guiding perfusions in the future. So I'm on the end, and thank you very much for your attention.
Thank you so much for an interesting talk. Is there any questions from the audience? Or the panel?
Thank you very much for this excellent presentation, Hans-Jörg. You talked about bad and good suction, you know. Have you ever considered to use a cell saver to send some of the field blood there instead of using the oxygenator?
Cell saver blood, we use autotransfusions for every case, of course. And for cabbage, for example, it's no reason to there's so low volume of suction blood. We just use cell saving for cabbage. We never get suction blood back into the system for cabbage. But the story with you during open heart surgery is completely different. Then you have to deal with much more blood. And vent blood, as I say, is kind of good blood because it was not a long time in contact with air. Is less activated as the pericardial shed blood. You know, that makes sense then to separate them. And you have reservoirs, and you have two different ports, and you can suck the vent blood in one chamber, and the blue sucker in another one. And then you can decide which one you give back. So normally the vent blood you can give back earlier if it's a lot of blood, and otherwise you also can wash it if you want. But that's why I make a difference between suction blood. The high activated blood is the shed blood. That's well documented.
Yeah, okay, thank you.
So we introduce the other presentation, pulsatile minimally invasive perfusion obstacles and advantages by Markus Enika from the Department of Cardiothoracic Surgery from Germany.
Okay, good morning, everyone, dear audience, dear chairpersons. First of all, thanks for inviting me, for giving me the opportunity to present some data here. I will share my presentation. Okay. First, disclosure, we have used a pump in these experiments, in some of these experiments, which was a loaner from a company, which was provided for the duration of these experiments free of charge. First, to the background. Everybody thinks that pulsatile perfusion can improve organ perfusion during cardiopulmonary bypass, especially by improving brain perfusion and kidney perfusion. Although the clinical evidence is somewhat contradictory. We also conducted a pulsatility trial in Ulm at our own medical center. We compared CABG patients with MiEC pulsatile versus non-pulsatile. We saw an improved urinary excretion by pulsation, and we also saw transient TPA elevation, but it did not alter the fibrinolytic balance overall. So this is also not very impressive, and this led to the hypothesis that the pulsatile energy which actually arrives in the patient might be too low. And therefore we went back to mock circulation to investigate this issue. Let me first start with a little bit of background, should not be too technical. We can calculate the energy provided by perfusion from terms including the flow and the pressure. If you look at this EEP formula, if the flow does not alter, these flow terms cancel out, and EEP is simply equivalent to the pressure. However, if the flow alternates by pulsation, you gain some energy, and this is calculated as the surplus hemodynamic energy, or SHE, in the lower formula. And this is normally normalized to the mean arterial pressure, so you will see the results as % of MAP in a couple of slides. And our idea was basically to optimize the extracorporeal circuit to maximize SHE, and you can do that in the mock circulation without harming any patients. We used different types of pumps, default roller pumps. We used these DP3 diagonal pumps as non-occlusive pumps. And we also used a prototype pump, positive displacement pump. In most experiments, regular kit tubing was used. We used dextran solution as a blood replacement. There was an oxygenator present with a heater cooler unit at 37 degrees. We used aortic and femoral cannulas as needed. The peripheral resistance of the aortic model was adjustable to give physiological flow and pressure readings in the side vessels. And we used lots of flow and pressure probes to see what's happening. The aortic model was a compliant model, very similar in its elastic properties to a native aorta. First of all, we checked the tubing, the influence of tubing on SHE transfer. There was a paper by Wong et al. From 2017 that claimed that high compliance silicone tubing caused a higher transfer of energy into the patient. We simply could not believe that, and we were actually able to demonstrate that this was misinterpretation in the original paper, because they used a non-compliant pseudo patient in their results. But for us, the most interesting result was not that the kit tubing was in fact better as we expected, but the dependence on the flow. As you can see, the SHE has a maximum around 1.5 liters per min, which is okay for pediatric surgery, for example. But adult patients need a lot higher flow, and SHE drops again at these high flow rates. Next, we checked the influence of oxygenators and of aortic cannulas. You can see on the upper left, the pressure gradients differ by a factor of 2 between different makes and models. Of course, it's better to choose an oxygenator with a low pressure gradient, because this relieves the pump from unnecessary work. And on the right-hand side, you see the SHE. It's very similar, except for this one oxygenator with an exceptional high pressure gradient. But we choose actually the blue one in these images for further results. The influence of the aortic cannula basically depends on the size. 15 French gave somewhat limited SHE transfer, but 21 or 23 was essentially as identical. So we concluded the cannula has to be big enough, but not huge. Next, we optimize the console settings. That is what influences the DP3 pumps. And we started from the empirical settings from our perfusionists. They used a frequency of 50 BPM, a systolic percentage 50%, and a speed gain of 2,300 during pulsation. And this gives the red curves in the images on the right. We made a sort of a grid optimization and ended up with lower frequency at 40 BPM, 35% systolic percentage, and the maximum possible speed gain. And you can see the blue curves, they're a lot higher, although the main difference is again at 1.5 liters per minute. If you look at the highest flow rates, there is still something to gain, but not that impressive. On the right-hand side, you see the pulse amplitude, the pulse pressure. And as you can see, a high pulse pressure does not necessarily translate to a high SHE. These are really different entities. Next, we ran a couple of experiments with dual DP3 pumps. The idea was to run 2 pumps at half speed rather than having 1 pump max out at maximum speed at the highest flow rates. And we investigated different combinations. For example, pulsatile pump and another non-pulsatile pump, or both pumps pulsatile synchronized. And we also investigated whether it makes a difference to run both pumps through the oxygenator or have 1 pump bypass the oxygenator. The results was essentially best is to run both pumps at the same speed, both pulsating, and have only one running through the oxygenator. And this gave the best readings, although the improvements over a single DP3 setup is not very impressive. So this was interesting, but did actually not provide a solution to improve the SHE at high flow rates. Next, we ran a couple of experiments with this pump prototype, which was provided by the Triphasic company from Australia. This is a positive displacement pump, entirely different principle compared to these DP3 pumps. And we ran a complete characterization of this pump, but I will show only one set of experiments to show you the principle. The stroke volume on the x-axis is comparable to the RPM setting of a DP3 pump. The higher the setting is, the more the flow is. And this prototype actually achieved maximum flows of 2.5 liters and a limited pressure, as you can see, but then again, it was a prototype. But if you look at the right-hand side, the SHE was in some settings above 50%, and at the highest flow rate, you could still achieve more than 30% of SHE, which is far higher than any DP3 could ever achieve. So this was very promising. Finally, we had a look at femoral cannulas. They're not only interesting in MiECT, but of course also when using a VA ECMO, for example. And we were basically interested in looking at cannula types which provide an additional distal perfusion. So they have additional holes pointing backwards to perfuse the cannulated leg. And main focus was to see whether they actually provide appropriate distal perfusion. And as you can see from these images, we compared these with regular femoral cannulas and regular cannulas supplemented with an additional distal perfusion cannula. And I would skip the part of the cannulas themselves and focus on the effective pulsation. We were actually thinking that pulsation might improve the distal perfusion by simply adding a pulse to the cannula, but in most cases pulsation was actually worse. So it did not help distal perfusion in these experiments. A couple of cannula, the Rivas, and with or without an additional cannula were actually best and were not affected by pulsation. So let me summarize this real quick. The kit tubing is perfectly fine, so you can use whatever you have. The pressure drop of the oxygenators is most likely more important than any effect on SHE. You might wish to review the diagonal pump settings because there's lots to gain, at least at lower flow rates. And you might wish to keep an eye on the progress with these positive displacement pumps, as they provided an excellent opportunity to improve the SHE. I would like to thank all the students that were involved in these experiments, and thank you for your attention.
Thank you so much for this interesting presentation. Very, very, very interesting. There are questions from the audience. Okay, from the panel, from our panel. Okay.
Thanks again for a very nice talk. Do you think clinically using pulsatile flow, are there any risks or drawbacks to potentially using this clinically? I think of things like shear stress or potential cavitation as you have the flow rapidly increasing and decreasing.
Well, you have to keep that in mind, that you can produce cavitation if you exaggerate the pulse pressure, for example. But otherwise, I think the risks are limited, given that the heart itself is a pulsatile pump by design. So if you keep it within these limits, I think you should be pretty much safe.
Thank you.
I have one question for you. Do you see in your experience that the use of pulsatile flow, in particular in high level of hematocrits, increase the plasma-free hemoglobin in your experience?
I think we cannot answer this question from our perfusion model, because we simply use a different type of medium, and we cannot analyze these effects as much as you could analyze them in a patient.
Okay, thank you. Thank you so much.
Thank you.
If we not have other question, we introduce other caller, please.
Moving on to our next speaker is Lauren Janta from Toronto General Hospital, one of my perfusion colleagues, and I'm happy to invite her up to the podium to speak about the use of type 1 MiECT for lung transplantation.
Morning, everyone. Thanks for having me, faculty. It's my first time coming to this conference, so I'm really excited to be here. I've been at Toronto General for about 8 years now, and since I started, we've been doing extensive work on the lung transplant field. So today, I'm going to talk to you about our experience. There we go. You go ahead. Mm-hmm. Okay. Great. Okay. So we started our lung transplant journey a long, long time ago. 1983 was our first successful lung transplant. Back it up. There we go. It's moving by itself. So over the past 40 years, we've completed over 3,000 lung transplants, and last year alone, we hit our new record with 217 lung transplants last year. This is a general outtake of our outcomes post-transplant. So 1 month post, we're at 98%, 1 year 88, and then 5-year success 65. So historically speaking, we would either do one of two things with our lung transplants. We would either do no support, which would be just the surgery, we would be on standby, or we would do a full intraoperative support on conventional cardiopulmonary bypass. In 2012, we started introducing the idea of using intraoperative ECMO instead of conventional bypass. However, we would still keep the bypass pump in the room just in case something happened or there was a tide change in the procedure, and we could easily initiate bypass. Every case we do, we would also utilize auto transfusion with our cell saver. So a year later, 2013, we actually decided to make our intraoperative ECMO a standard of care, and we would opt to try to use it in any cases that required support from perfusion. Currently, we're actually just over 80% of all of our lung transplants using intraoperative ECMO. This is a bit of a trend that we've seen. So the first 2012 is prior to introducing our ECMO circuit, where we were mostly doing off-pump, no support lung transplants. And anything that we needed to go on, we had that orange line there for conventional bypass. In 2012, when we introduced our ECMO, you can see we started to see a change of tides from using intraoperative ECMO more and more as the years progressed. And to the point that we're at now, this chart only goes up to 2019, where we were about 75% intraoperative ECMO based, and now we're up to about 85%. And some of that can be attributed to the fact that we're starting to use more of a routine approach with some of our surgeons. We have quite a few lung transplant surgeons at our center. We've got about 5 or 6, and some of them are starting to just routinely go on intraoperative ECMO just as a precaution, prophylactically. And then we don't have that event where you maybe have to crash on partway through, and it's just a safer, more successful outcome. This is the setup that we have at our OR. So we've still got our conventional circuit tucked away in the corner on the patient's left side there. We've got our cell saver on that side as well, which we use every case. And then on the other side of the patient, we've got our primed and ready to go intraoperative ECMO. Just quickly going to touch on some key differences. Of course, we're pretty familiar with the difference between the two. This is just more specific to our center. So some of the things to point out, our ACT targets are significantly different. We're targeting 160 to 180, maintaining intraoperative ECMO flows. And our pump prime volumes are significantly different, of course. We're just over 50% of our conventional prime volume, sitting just under 600 mils for ECMO. So guidelines, we consider both recipient and donor-related criteria when we're deciding who's going on intraoperative ECMO for their transplant. In terms of recipient, patients that come in with pulmonary hypertension or borderline ischemic heart disease, those are definitely good candidates to put on intraoperative ECMO right from the start, and we won't wait to see what happens as we go. Smaller patients are also a good candidate for intraoperative ECMO. So small chests or pediatric patients, just because it is hard to mechanically manipulate the chest in these patients. Anyone with airway difficulties coming in preoperatively, or while we're operating, sometimes we'll see hypoxemia or high PA pressures after the contralateral pneumonectomy. Typically, we're talking hypoxemia requiring more than 70% FiO2, and high PA pressures being usually over 50 millimeters of mercury. In terms of donor-related criteria, anything that would make the donor lungs high risk, so a long ischemic time if they're coming from far, or if there's a degree of edema, either before or if they do EVLP, they still see a little bit of edema, we'll tend to just go on ECMO from the start. So our ECMO circuit is technically classified as a type 1 MiECT with very, very simple structure. We've got our centrifugal pump, a Quadrox I oxygenator, and then Corteva or heparin-coated tubing. We don't have any of the bells and whistles that are available to us. We like to keep it simple it's foolproof. So we don't have any AV bridge, we don't have manifolds, there's no additional monitoring, so we don't have saturation or pressure isolators, and we don't have any prime lines built into the system. In the event of an emergency, we do have an option to add a prime line if we need to flush the circuit if air isn't trained, but we don't conventionally run with it. So here's the picture of our intraoperative circuit pre-transplant. So we can see we've got a little black box that is our bubble detector that we keep pre-pump. After the pump, we also have a very old school flow probe, that gray box there. And then carrying forward, we have a pre and post pigtail on our quadrox, and then it goes right back to the patient. Anticoagulation-wise, we're monitoring ACTs for these operations. We cannulate with about 60 units per kg, and we're targeting over 200 seconds for our actual cannulation. From there, we'll let it drift down, and we'll be targeting anywhere from 160 to 180 throughout the procedure, checking our ACTs about every 30 minutes, and we use low-range ACT cuvettes with the hemocron. If the ACT does drop below 160 seconds, we will give more heparin. It's usually up to the discretion of the surgeon. It's usually between somewhere 500 and 1,000 units, kind of depends where we are in the operation. So cannulation-wise, we're pretty streamlined at this point with our cannulation. We're always draining right atrium with a 32 French single-stage cannula. Some surgeons prefer to use the small 2-stage, but I'd say majority of our patients are using the small 32 French. Infusion, everyone is the same across the board. We use a 20 French Medtronic EOPA, and that's because regardless of the size, we're always targeting partial support, so there's no need to go bigger. This cannulation will give us great exposure. We cannulate easily with our clamshell incision, which majority of our transplants are, unless we're doing single. And there's minimal risk-related cannulation and vascular complications. So intraoperatively speaking, because we have a very simple circuit, we work very closely with anesthesia, trying to keep patient parameters in check. So on average, the only thing we're really changing on our end is going to be flows. And in flows, sometimes we can increase and decrease the pressure. However, still keeping in mind we don't want to flow too high because then we're going to ruin the pulsatility that we're trying to maintain. So when volume status is a problem, hypovolemia, anesthesia will be the one to provide PRBCs, plasma, albumin, whatever it is. And hemodynamic stability as well. They'll give all of their drugs on their end as we don't have a sampling manifold. So I summarized, there's a lot of research out there talking about the advantages of using intraoperative ECMO versus conventional bypass. This is the short list. Generally speaking, you do have lower transfusion requirements, and that results in fewer reoperations, just generally speaking, because there's less bleeding. Okay, we're targeting lower ACTs, we're giving less heparin. It does translate in the results. It also provides a reduced length of mechanical ventilation postoperatively, and that we will talk about on the next slide, but it's in relation to single lung ventilation when we have one lung transplanted and the contralateral pneumonectomy. We also see reduced rates of primary graft dysfunction, and this is basically in part solely to the protective reperfusion that we provide. We're going to talk about that in the next slide too. And they've generally saw a lower rate of acute renal failure and dialysis requirements in these patients. Another advantage is there's a decreased requirement for postoperative ECMO. Usually this postoperative ECMO, if they do go on, is in the form of a VV, very, very temporary support, usually 48 hours post-op, and then they're usually weaning off. And finally, it translates to an overall reduced length of stay in the ICU and in the hospital, and that translates to lower in-hospital mortality and a survival advantage at 3, 6, and 9 months post-op. So why use intraoperative ECMO during lung transplants? There is a rationale. You are definitely only providing partial support. However, it is enough to help maintain hemodynamic stability in the patient. Blood pressure and SATs remain stable despite all of the manipulation by the surgeon throughout the operation. The surgeon also gets to experience a superior visualization of the surgical field when compared with no support. And it also provides the surgeon a chance to simply correct any anastomotic bleeding that they notice during reperfusion. You generally see reduced blood flow through the heart and lungs, which in turn decreases the risk of surgical bleeding. And now we're getting into the point of the lung protective ventilation. So typically, once the first lung is transplanted and the contralateral pneumonectomy happens, we do see really, really high ventilation pressures into that newly transplanted lung with no support. This is obviously problematic, overexpansion of alveoli and poor post-op outcomes in those lungs. So having intraoperative ECMO providing single lung ventilation is a much easier thing to do with much less pressures in that lung. And then the most important thing out of all of these options is the chance to have a protective, controlled reperfusion. So we know that these lungs are most vulnerable when we take the cross clamp off. They're most vulnerable during that reperfusion phase. So being on an intraoperative ECMO circuit allows a lower blood flow into the pulmonary system, which in turn allows a much slower controlled reperfusion, not only for the first 5 or 10 minutes when the clamp comes off, but the entire operation. With that being said, it's not always a clear shoot, okay, everybody gets intraoperative ECMO, we're done. Instead, there are still situations that we have where we do need to utilize our cardiopulmonary bypass conventional circuit. These are patients who require cardiac surgery along with their lung transplants. Specifically speaking, it's usually an open chamber procedure, so valves, any kind of aortic reconstruction. We have been transferring to remaining on intraoperative ECMO for our ACVs that go with lung transplants. We've got a few surgeons at our center that do off pump, so they're happy to come in and they do the ACV while we're reperfusing. Another situation in which we would need to convert to full bypass would be a pulmonary artery aneurysm. We don't see this often, thankfully, but when it does happen, a lot of the times it's just very hard to visualize anything and to get control of the bleeding, so we will transition on to full bypass. And then finally, any kind of anastomoses that the surgeon's doing that requires an open heart chamber, so open atrium anastomoses. So all in all, intraoperative ECMO has completely revolutionized our lung transplant system at Toronto General. It's replaced our conventional bypass, it's our new gold standard, and we're seeing really great results using it. We're also seeing a declining number of transplants that are occurring with no support because it's actually proving to be much more beneficial to just be on intraoperative ECMO the entire time. Every lung transplant is different, however. It's not a one-size-fits-all approach, and we do have recipient and donor factors that we have to consider when we're deciding between our 3 options for each lung transplant. And finally, there are so many advantages in the literature that's associated with using intraoperative ECMO. It's not only intraoperatively seen, it's also postoperatively seen for months and months later. So it's definitely a great approach for lung transplants. Thank you.
Thank you very much, Lauren. Any questions from the panel or the audience?
Congratulations, really impressed. And so good to use MiECTiS for the lung transplantation. I noticed that you have an increasement of implementation of ECMOs from 75 to 85% currently, right? Is it COVID affect any of this number, or is just?
So we actually saw a huge decline in our lung transplant program during ECMO or during COVID. And that was solely because so many of the donor lungs that we were getting either were at risk of having COVID or we didn't have the ability to test them before. And so we actually saw a huge decrease in overall during COVID. Now we're right back up to where we were, but I don't think I would attribute it to COVID. I would attribute it to the general paradigm shift that we're seeing with our surgeons. There are a few surgeons that are becoming strong believers in going on intraoperative ECMO right from the start with as many patients as they can, despite hemodynamic stability and, you know, reasonable PA pressures and reasonable high, oxygenation. So I think it's just a routine shift. We're trying our best to implement
So
it.
more experienced surgeons and more experienced perfusionists.
Yeah.
Is it? Yeah. Okay. Great. Thank you.
Thank you so much for this beautiful presentation. If there aren't other questions, I introduce my friends and colleague Youssef El Dasuki, Senior Clinical Perfusionist from Sorbonne University, with the topics of advances in perfusion technologies, introducing the new hybrid system in hypobaric oxygenator. Please, Youssef, thank you.
Good morning. So really thank you to give me this opportunity to be with you, Professor Anastasis, but also Professor Polychronis. It's really honor to be with you in the MiECTiS. So actually, I would like to start with this disclosure. I have a potential conflict of interest since I'm employed by Spectrum Medical as Director of Clinical Education. The objective of my presentation is not to promote the new hybrid system, and I acknowledge that the potential influence to this relationship may have a bias on the content. I am committed to transparency and welcome any question or discussion regarding this disclosure. So to start my presentation, if we look today to the unmet need, or if you ask any perfusionist or cardiac surgeon, what do you want to achieve in cardiac surgery? And you will see that all the benefit of MiECTiS that have been presented, especially in this paper published in 2019 by Professor Anastasis, you can see that all the benefits that any cardiac surgeon and perfusion are looking is in the MiECTiS system. Reduction of the hemodilution, reduction in the transfusion rate, shorter stay in the ICU, reduction of coagulation for response and monoplatelet interaction, and reduction in the inflammatory response and the enhanced recovery after cardiac surgery. So my personal experience in MiECTiS started in 2002. So I started my career in 2002 at Hospital Saint Joseph in Paris with Dr. Yves Fromes. And during this period, the hospital was using this kind of circuit with the small console, HL20, two position. We have the centrifugal pump, the oxygenator, the venous bubble trap. At the beginning, was using the collapsible bag, and later on, it was stopped by Maquet, and we started to use the reservoir. So during this period, really, I have the chance to be trained on the MiECTiS, and during this period, we was doing all kind of CABG and aortic valve replacement, and it was the only indication. And then in 2004, 2005, Sorin Group introduced the ECHO, and the ECHO was amazing because we have this venous bubble trap, and with the application, the air purge control, where you have a sensor on the venous line, you can detect the air, and system automatically, let's say, can remove the air actively from the system. And it was amazing because with this system, we started to do all kind of cases at this time in St. Joseph Hospital. So we extended our indication to complex cases like Tyrone David, Bental, mitral valve, repair, replacement, any kind of surgery we was doing with this system. With this success, we have been approached by Sorin Group at this time to do proctoring for center interested in MiECTiS. So the beauty of this period, there was a lot of presentation on MiECTiS with the advantage of MiECTiS, like you presented yesterday in your presentation. People coming from EACTS, mainly cardiac surgeon, was interested in the concept of MiECTiS. So let's do MiECTiS. It was like this. We was invited by the company to come as expert and to do some training to start the program. And you will see that we go to the hospital, we present the concept of MiECTiS, we supported them in the setup, in the first 2-3 clinical case, and then we left the hospital. You will notify that after this, a lot of centers that started this approach, they stop because lack of knowledge, lack of experience. Perfusionists was not interested because they was not involved from the beginning. It was the idea of the surgeon. So they didn't say yes at the beginning. They started. So we see a lot of centers start and stop. And it was not really very consistent, this approach. In 2014, I have the chance to join Livanova as medical affairs manager in the Middle East and the international region. And you know, MiECT is a topic very close to my heart. So for me, really, the advantage of MiECT should benefit from a lot of center. So we started our activity to promote MiECT extensively with the help of some of the key opinion leaders available with us today, Professor Serdar, Ignacio. So what we did that we started to look after the educational program because we felt that there is a gap in the educational program. And we did a lot in terms of training activity, including simulation, including a comprehensive program where the center interested in MiECT should follow a sort of education program with the help of Professor Serdar, where we go through all the aspects of the MiECT in simulation model, in animal model, before going to the OR and supported some cases. And we was doing this successfully for the last 6 years with a lot of on-site training and clinical cases. The need coming, as you mentioned yesterday, from the expansion of mini-invasive program. So we saw today there's a lot of mini-invasive program coming outside with different hospitals, especially in the Middle East. And we see a lot of people was looking for optimizing the MiECT setup or the CPB setup. And you will see that Turkey was one of the most interested country in the MiECT. However, we have a lot of other countries like Saudi Arabia, Kuwait, Japan, India, Singapore, and Chile, where we did some activity, and they was really keen to move into MiECT. You will see that in 2003, we performed 1,500 case in Turkey, MiECT case, including cabbage, complex surgery, and let's say, for sure, aortic valve replacement, those kind. And the setup that we was using was somehow universal. So we didn't have the possibility to customize the custom pack. So here we are talking about Inspire 6 or 8, centrifugal pump, venous bubble trap, and the Medicard reservoir to manage non-activated blood during complex cases with association with the ATS. So, and this was working well. So the result of this, out of 18 cardiac center in different cities, Istanbul, Ankara, Izmir, Konya, and other, with the support at least 5 clinical cases at the beginning, with more than 10 advanced courses that we deliver in a training research center where we have the possibility to do simulation, but also animal model before going and to perform the cases on the patient. We can see that out of those 18 centers, only 8 cardiac center is still using the MiECT for cabbage and aortic valve replacement. So today, my presentation would start from here because I will talk about the hybrid system. My concern is not about the 8 center because the 8 center now, they are in the state of the art. They are doing the best possible solution in cardiopulmonary with all the advantage of the MiECT that we know. However, we still have 10 cardiac center that we need to improve their clinical practice. We need to improve the outcome of the CPB. And this is where if we assess the problem of this 10 center, because today, if we look to this current problem and we discuss with any center doing MiECT, he will not acknowledge them. So we can manage the heart. We don't have heart distended. If you manage well MiECT, you don't have a heart distended. You don't have any problem with the anesthesia protocol. You don't have any problem with accumulation of low DO2 and low flow because we know how to do MiECT. However, if you look to this 10 center, the main concern that they feel that it's complex to use with limited indication. So only cabbage, only aortic valve, where they want to extend to other possible cases. Also, there was a big discussion with the cardiac surgeons, the anesthesia, about the change, of setup of protocol, because we know it's more sensitive on the hemodynamic side. And for sure, for the surgeons, the most important aspect, working on a distended heart, is not optional. So he need really to be comfortable, especially with the mini-invasive setup. So having a good field, surgical field, it's very important. We notice also something that we have a lot of change in the flow during the MiECT because it is depend on the preload. So also we notice if we look to the area under the curve with the oxygen delivery, we have accumulation that can be really, we should be worried about it. and for sure the air handling and the blood loss. The last point, and it have been discussed with Jenny presentation when he talked about the cardiotomy and vented blood, the use of ATS. The use of ATS is really very good, especially in CABG, where amount of blood is very low. However, in our experience, autotransfusion was used in all the cases. And you will see in complex cases, when surgeons don't take care too much about the cell saver, and the amount of blood coming to the cell saver is more than 1 liter, here you start to have problem with the coagulation, especially for a patient of 60, 70 kilo, where you are losing more than 20% of the total blood volume, and you need to compensate with platelets, PFC. So all the advantage that we are trying to associate, we lose them somehow with the mismanagement, not with the concept, mismanagement of the suction line. So yesterday, Mike did a wonderful introduction about the importance of the venous reservoir, because we are talking about the oxygenator, how to improve the oxygenator. However, venous reservoir for a long time have been considered as a bucket, just to have the blood into a space, you know, with some filtration level. However, we know that interface with air, we know that also the keep it in contact with foreign material like silicone and the antifoaming agent. This is something really can have a big impact on the inflammatory response. So there was a lot of discussion long time ago about how to improve this, the design of the venous reservoir, and make it a little bit more physiological to be used. So first of all, the objective was to create something simple to use by anyone. We have passive effective air handling, minimizing the blood-air interface. We can use the VAVD because this is something really needed, especially with the mini-invasive. And we have the possibility to handle in a separate way the vent and the sucker. So Spectrum Medical was able to introduce recently to the market the hybrid system. It's combined of the best traits of the hard venous reservoir, soft shelf, and mini bypass. And all of this is combined into easy use system. So if we look to the functional design of this reservoir, you will see that it's really easy to use as a hard venous, like any hard venous reservoir. So it doesn't require any education or any effort to be adopted or to be implemented. It is safer than a venous bag because we know also the closed system have a lot of advantage. However, in terms of adoption, it have been always limited, the adoption of the closed system, due to the complexity to the management for the center not used to those kind of system. It can be operated safely with a very low volume and have a really superior air handling. The most important part is that vacuum can be applied without any complication. And also we have this possibility to manage activated blood versus non-activated blood, because as you can see, the reservoir is divided into two chambers. In the first chamber, we have the non-activated blood. On the other chamber, we can manage the activated blood with the possibility to connect to the autotransfusion system and to process the blood through the autotransfusion system. I would like to present for you some internal data in vitro, because as you know, this product is really very new and there is a lot of amount of data available from cardiac center. So we did some tests internally regarding the air challenge. So measuring the air at the outlet of the reservoir. And you can see here in comparison with other, I didn't want to show the other as a trade name of other reservoirs. So you can see here in blue, the amount of bubble coming from the hybrid versus other model used with different flow during this test. And here also you can see the same test with no cardiotomy air versus cardiotomy air 300 cc per minute. And you can see the difference between the hybrid model and other model available in the market. We did also some tests related to the inflammatory and the interface of the blood with the air. And also here, it's amazing to see that we have a significant reduction in terms of air interface when you compare also the hybrid system to other system also available in the market. Our system can be combined with the hypobaric oxygenator. So I'm not going to develop or to talk about the hypobaric oxygenator because it's another topic. Just to highlight that today also we have an oxygenator where we can eliminate denitrogen completely the blood, and we can have a control on the saturation during the delivery to have a better control on the PO2. So the combination of the oxygenator with the centrifugal pump and the hybrid system really can give a very good alternative or option for the center interested in the optimized system and take the advantage of all the MiEC can do and applicated this on daily basis. So actually, also I want to present the early result of this study. We are doing an assessment of inflammatory response and the clinical outcome in cardiopulmonary bypass comparative study comparing 3 groups, the hybrid system, the MiEC, and conventional CPB system. We are doing this study with the help of Professor Kan Kirali in Koshulu, Istanbul, Turkey, where they have very big load of MiEC cases. So it was really very good to have the same setup for the 3 devices and also have the same surgical technique and have this comparison on the inflammatory response. So it is a comparative prospective study, and we are going to collect serum level of inflammatory marker, including interleukin 6, interleukin 8, tumor alpha factor, and with different type of measurement. The post-operative outcome will be also assessed, including the incidence of major adverse cardiac event, post-operative complications like stroke, renal failure, respiratory complication, length of stay and overall length of ICU stay and overall length of hospital stay. So just because we didn't finalize, so we are at half, of the study target, because here we are targeting 50 cases from each group, and today we are approximately around 30-35 patients in each group. So I don't have the details of all the data, but we noticed that in terms of interleukin 6 level, when we compare hybrid MiEC system, we have a lower in comparison to conventional group, which is something have been, I believe, demonstrated in many studies previously. For the interleukin 8, there was no statistical difference right after anesthesia and 5 minutes after bypass initiation. However, it was significantly higher in conventional group at 6, 12, and 24 hours. Tumor alpha was significantly higher in the conventional group versus the 2 other group. And until today, the blood transfusion rate also was significant lower in the hybrid and MiEC group. So just to conclude that today, MiEC, I believe, is the best option in cardiac surgery. And I believe we should use MiEC when MiEC it is possible and it can fit with the setup of the hospital. However, due to the complexities that we know and we discussed many times related to the education, related to the behavior, the interest of the cardiac center, today we can propose alternative, and this is what we call optimization. And today there was a lot of presentation about optimization, because this is something really can give all the advantage of the MiEC that we know today in an easy way for all those centers that they are looking for optimization, but it is not possible to adopt the MiEC. So the hybrid system really can be easy to use by any perfusionist, any cardiac team. We have a reduction of up to 600% in surface area compared to conventional setup. The impact on the platelet activation, really it have been approved, and now the studies that we are doing, and we will have the result very soon, it's confirming this. We have a very limited air-blood interface leading for a significant decrease in the post-operative inflammatory response, low priming volume, and lower gaseous microemboli generation compared to the existing venous reservoir. Thank you for your attention.
Thank you, Youssef, for this really interesting presentation. There are questions from the audience, from the panelists, please. So I have a question for you. Is really interesting, this innovative technology, in particular a focus of gaseous microembolic activity. Do you think that the future of the research is about the gaseous microemboli and the use of this system, for example, with the vacuum in the minimal invasive procedure, you think that improved this perspective?
Yeah, I believe there is a big area, you know, and space to improve this impact, because it has been discussed during many meetings. You know, you can. I have been attending many EACTS, EBCP meeting. There is a lot of meeting ongoing where we are talking about the microemboli and how to improve microemboli. However, the system are still the same. So the same oxygenators that we have been using in the last 20 years is still the same that we are using today. Some improvement on the design of the arterial filter, but nothing major. So today I strongly believe that this approach, having new ideas, like Mike yesterday was trying to explain about LCD, but other possibility, you know, to be improved. And hypobaric, I believe, is one of the innovation that really can make impact on this topic. So yeah, I believe there is the possibility today. Also, what you are doing, example now with your presentation, you are going to present the endocatheter. And this is something really very important, because you will see that the amount of bubble entering the system can have an impact on the amount getting out of the system. So also having improvement at this stage and this level, this is really can have a good impact, you know, to improve those aspects during cardiopulmonary bypass.
Thank you, Youssef.
Thank you.
Great, thank you. I believe our next speaker is a pre-recorded talk by Mike O'Neill, a perfusionist in London, Ontario from Canada, and he will be speaking about microvascular monitoring during CPB.
Hello, everyone. My name is Mike O'Neill. I'm a perfusionist here in London, Ontario, Canada. Just going to present today on some of the research that I've conducted over the years and some of my insights on microvascular monitoring. So to help guide the optimal delivery of blood flow during bypass, perfusionists relies heavily on cardiac monitors that reflect global perfusion status or macro hemodynamics. So this includes parameters such as heart rate and mean arterial pressure, and even values such as lactate and venous oxygen saturations are still representative of central perfusion markers. However, normalization of these parameters do not always ensure that sufficient oxygenation occurs at the microvascular level. So therefore, since the macro hemodynamics is limited in predicting the state of the microcirculation, there's an increased need for microvascular monitors that can help guide therapeutic targets during bypass and improve clinical outcomes. When we talk about goal-directed perfusion, this essentially is a type of blood flow management technique, with the primary focus being on global oxygen delivery and some other calculations. Even oxygen delivery, or GDP, calculated values are considered as macro hemodynamic values. If the microcirculation is injured or unhealthy for whatever reason, it doesn't matter how much oxygen is delivered to the tissues. This has been documented in extensive research with sepsis patients. Therefore, you know, it's the microvascular blood flow and the control mechanisms that are just as important as the oxygenation values themselves. So these are just some of the monitoring devices that we've used in the past. Although these technologies help us to better understand microvascular perfusion, they do come with some limitations. First, OPS imaging provides only a snapshot of the microcirculation. Too much pressure may underestimate blood flow, and there's a lot of movement artifacts involved. STO2 values are viewed primarily as a measure of regional venous oxygen saturation, which is not a true indicator of microvascular blood flow and the regulation of oxygen. As I said, it's that control mechanism that we're after. And again, a need for monitors exists to continuously track real-time changes of red blood cell distribution within the microcirculation. So this leads to our subsequent study. Basically, we asked the question of whether we can track changes in microvascular hemoglobin levels over time and use this as a surrogate for red blood cell distribution. So we aim to investigate this by applying a custom broadband wave NIRS monitor. And we had previously built this and used it successfully in the ICU at LHSC. And we looked to determine the feasibility of using it on bypass. Our hypothesis was that this isosbestic NIRS device would be successful to provide continuous monitoring of MHC values in the skeletal muscle of the thigh in real time. In fact, we actually believe that changes in MHC would correlate to some various interventions during bypass and maybe provide some insights into microvascular function. So with the design and build of our own NIRS device, therefore we have the luxury of accessing the raw data that's needed to reflect the time-dependent variability in MHC. And you can see here, this device is clearly contained in a carton. Looks like it belongs in a hospital already. Key to our analysis is processing the light intensity signal from our spectrometer at the isosbestic wavelength, like I said. And this is of hemoglobin, of course, in the near infrared range, which occurs at approximately 798 nanometers. So as at this wavelength, the amount of light absorbed by hemoglobin is independent of whether it's oxygenated or not. Therefore, we don't measure hemoglobin directly, but we measure changes in the optical density at that isosbestic wavelength, which gives us changes in MHC over time. So this is a single patient representation from our study that shows macrohemodynamic data versus the first time showing delta OD measurements of the microcirculation. We had presented this back in 2019, this particular graph, and it looks a lot like goal-directed perfusion that we see on some of the heart-lung machines today, except for the fact that we're focusing at the microvascular level. So obviously in figure A, this is pump flow rate. Figure B represents the patient's mean arterial blood pressure. And finally, the blue curve in figure C shows changes in optical density and how it's affected by flow rate and mean arterial pressure. Also in figure C, the dotted black line represents the patient's own baseline delta OD values, which we had determined pre-bypass. And these values are important as we use them for one of our key measurements, being the area below baseline. Again, a metric that has become similar to goal-directed perfusion. When we zoom in on this NIRS signal, we can see there's distinct changes in that optical density, and this is associated with mechanical ventilation. So in figure A, the OD signal can be seen just prior to pump on, and this is in association with the ventilator, and then it disappears once bypass is initiated and the ventilator is turned off. So you can see this sawtooth pattern here being the ventilator. So this pattern represents changes in MHC as the venous return to the heart fluctuates with each breath of the mechanical ventilator due to changes in the intrathoracic pressure. And then in figure B, obviously, the ventilator is turned back on just prior to the end of bypass, and these oscillations, ventilator signals reappear. So as a feasibility study, these changes that we see here in optical density were very encouraging and added some strength to the fact that we were able to detect what we had hoped for. Now, for the sake of time, I'll just fast forward to a multilinear regression model. So in the case of area below baseline, the area multilinear regression revealed that area below baseline was significantly dependent on the pump duration. So in fact, for every 10-minute increase in the pump time, the area below baseline was increased by 0.026 units with a p-value of 0.001. Our second multilinear regression model revealed that post-pump lactate was significantly dependent on the area below baseline. So in fact, for every 1 unit increase in the area below baseline, post-pump lactate was increased by 87.6% with a p-value of 0.025. So in summary, as area below baseline increases with pump time, this would suggest that tissues are less well perfused with hemoglobin. When we look at lactate versus the area below baseline, we see as the area below baseline goes up, as does the lactate. So this leads us to our final study. And in this one, we ask ourselves, is it possible to detect the dynamic behavior that speaks to the regulation of microvascular blood flow? So using laser Doppler flow study concepts, we applied a continuous wavelet transform analysis to that delta OD time series that I just talked about. And we did this to reflect the dynamic variability in red blood cell distribution. And this was done at some key time points during bypass. By looking at the dynamics of hemoglobin content, we can gain insights in terms of the regulatory system. And obviously, this may not be reflected in some of the macro hemodynamic data that we collect. So our hypothesis was that changes in signal power at various frequency bands associated with microvascular origin will happen within and between patients, and that this information may provide some insight on dynamic variability as the microvasculature adapts to oxygen supply and demand situations. So LDF technology has been used to study the periodic oscillations that occur during microvascular perfusion of the skin. So in doing so, they've defined 6 frequency bands, each linked to a proposed physiological event. And these events include intrinsic or local mechanisms of regulation, such as metabolic in band 1, endothelial regulation, band 2, neurogenic, band 3, and myogenic, band 4. As well as some of the extrinsic or central mechanisms, such as respiratory, found in band 5, and cardiac rhythms found in band 6. So this figure represents that of a single patient data set with the delta OD time series shown at the top in blue. The colored image below is a plot of power versus frequency versus time for oscillations that are attributed to components of the microvascular system. So the color tells us what power is associated with the wavelet at every frequency over the time interval. The figure to the right shows that the global power averaged for each frequency band over time. Bands 2 to 4 that you see within the red rectangle represent the microvascular bands, and these are the ones that are of primary focus in our study. So I'll try and move my mouse without my computer crashing here. So basically you can see up here, this is the cardiac bands. Can't see this one too well, but it disappears once bypass is started and it reappears when bypass is discontinued. Same with the ventilator here. Disappears and comes back, ventilator turns back on. And then within the microvasculature, you can see these spikes along the way. And these are in sync with some phenylephrine boluses that we had given during bypass. And then some of the lower frequency bands here, especially at pump on, you can see it's very active here. And then again, it's very active at cross clamp off. So pump on, probably reflecting the hemodilutional effect, and maybe cross clamp off reflecting some type of ischemic reperfusion scenario. So the following figures show the effects of 4 boluses of phenylephrine spread over a 15-minute time interval during bypass. So figure A, there's similar global power. So each one's basically triangular shaped for each bolus. In figure B, most of the global power is concentrated at the base in bands 2 and 3 here. And that happens with each bolus of phenylephrine. However, here the phenylephrine causes vasoconstriction and abrupt changes in MHC. So this may not reflect a regulatory change in each frequency band, but rather a reflection of a simple time domain event. However, though, as the time between the boluses becomes less and the amount of global power seems to be decreasing as time goes on, and this happened despite an increase in dosage requirements. So basically, in other words, as phenylephrine became less effective or refractory, the global power had decreased. So again, for the sake of time, here are the percent power calculations for each frequency band through 2 to 4. So in figure A, the percent power in band 2 significantly increases at both pump on and cross clamp off time points when compared to pre-bypass values. Then they return to baseline values following bypass. Conversely, in figure B, a significant decrease in band 3 occurs at bypass on and cross clamp off, again relative to pre-bypass values with a subsequent return to baseline. And finally, in figure C, there was a significant decrease in higher frequency band 4 at a pump on only, with a slightly higher percent power seen post-bypass compared to pre-bypass values. So the shift in power to low frequency bands at pump on may be a reflection of hemodilution, as opposed to the impaired ability of the microvasculature to redistribute red blood cells. However, we do speculate that the microcirculation may be under stress as power shifts towards lower frequency oscillations at subsequent time points. So in summary, the current use of NIRS at the bedside is a non-optimal way of assessing oxygen delivery to a patient. A more practical monitor tracking MHC along with continuous wavelet transform analysis could be useful in providing information about oxygen supply and local tissue demand. And the second point there, our current research and related future work is an important first step and compelling prerequisite for such a monitor. There are some key metrics established from this research, which could be helpful in guiding perfusionists to improve best practices, such as maintaining MHC at or above relative to baseline levels. And the amount of time and magnitude spent below a certain threshold level could be a surrogate for low oxygen delivery and may be prognostic for adverse outcomes. And basically that becomes the holy grail, as the next steps would be to see what therapeutic interventions can be done to bring values closer to baseline. And finally, trends in B4 that we see that I didn't present due to time, related to changes in lactate are also very compelling. And that's it. Thank you very much. This could be the future of our goal-directed perfusion.
Okay, thank you so much. This is a recorded presentation, and I want to introduce the other presenter, Frank Alfwerk, Assistant Professor and Principal Investigator of the Cardiac Surgery Innovation Lab, with the presentation MiECTiS Principle to Change Conventional Extracorporeal Circulation Practice through Simulation-Based Training. Please, Professor.
Thank you, Dr. Condello, for the introduction, and Kalimera to all participants at the anniversary meeting in Thessaloniki, and obviously congratulations to the society. It's an honor to be here with you. I have a potential conflict of interest in that I'm appreciative of a conference travel grant from MiECTiS to present the trial results at the Cardiac Surgery Conference. And I would like to disclose that I'm an associate member of the scientific committee of the Society for Simulation in Europe. And I'm also a member of EURELSO's simulation working group. So we celebrate a decade of MiECTiS to promote research and application of minimally invasive extracorporeal circulation. But we have to acknowledge that the widespread adoption of MiEC seemed to face many barriers. And one reason could be the evidence, are the benefits unknown to the community, or do people feel there is conflicting evidence when comparing MiEC to state-of-the-art practice, for instance, advanced extracorporeal circulation, I'll talk about it later, or off-pump coronary artery bypass use in high volume and high expertise centers. And when trials show statistically significant numbers, are they also clinically relevant to patients? Moreover, a long learning curve, patients at risk during this learning curve, where we should not accept a non-inferiority endpoint when changing local practice. And there's the aspect of dedicated teams, which is problematic when people relocate or get ill. So the question is how to move forward. There are many best practices available in established high-volume MiEC centers, but how to bring these conventional extracorporeal circulation centers forward? Well, the first option is to implement MiEC in those centers. However, still have to overcome the aforementioned barriers. Another option is to implement MiEC-like practice, for instance, with these advanced extracorporeal circulation circuit systems and practice. And in a randomized controlled trial, we compared MiEC with this advanced extracorporeal circulation system, so a type 2 versus a type 4-like system with a centrifugal pump, soft shell reservoir, a fully coated system, cell-safe use. And we found no difference in our clinical endpoints, so no difference in MACE, mortality, transfusions, and length of stay, proving that might be a great alternative for some conventional centers. And we know that MiEC is more than just downsizing. It's not only about circuit optimization, it's also about team optimization. This was stretched out yesterday by Professor Anastasiadis as well. And I feel that simulation-based training might help to overcome the aforementioned barriers. Well, simulation-based training helps to advance knowledge, for instance, principles of cardiopulmonary bypass, about the difference between MiEC and conventional systems. It's about improving technical skills, such as surgical skills, which can be basic or advanced. It can be about surgical handling. It can be about cannulation, for instance, peripheral cannulation for the use of MiEC for minimally invasive cardiac surgery. But simulation-based training is also about non-technical skills, about crew resource management, about team training, to reduce human error with improving situational awareness, teamwork, leadership, and decision-making, also known as non-technical skills for surgeons. How effective is simulation-based training? Well, you can assess the effectiveness on 4 levels, the Kirkpatrick levels. So the first one is reaction. Do people like the training that is offered? The second level is about learning. Knowledge, technical skills, or confidence actually improve. The third level is about behavior. Is the behavior that is trained also applied during daily practice? And the fourth level is on, do patient outcomes actually improve? And unfortunately, studies regarding the effectiveness of simulation-based training on patient outcomes are rarely conducted. Next to MiEC, simulation-based training also has perceived barriers. And in this more than 20-year-old paper, we see examples of drill types of crisis management exercises, oxygenator problems, pump failure, air embolism. And reasons for not doing this simulation-based training is the individual responsibility. It's the motivation to do so, but also a lack of confidence in their own proficiency and a lack of expertise. Well, we do know that simulation-based training for cardiac surgery is effective, for instance, on anesthesiologists, non-technical skills, They improved compared before and after simulation-based training. Also, they were better than regular seminars and regular lectures. You can also use simulation-based training to state the importance of critical events checklists, for instance, during cardiopulmonary bypass. And if we look at behavioral outcomes, we know that if you follow the EACTS endoscopic mitral valve course, 1/3 of the participants reported to start minimal invasive mitral valve surgery program, showing an actual behavior change in practice. And if you look more closely to our practice, we look at the effectiveness of multidisciplinary cardiac surgery team training. It proves to improve surgeon communication, but not only that, also for the anesthesiologist, the perfusionist, and the team as a whole, showing these domains of the non-technical skills for surgeons. And often when we talk about simulation-based training, the term of high fidelity comes into play. But what is it? What is fidelity? Well, fidelity is about the realism, about simulation, about the simulator. It's not a quality mark. So a low fidelity simulator might be useful for novice learning. So for instance, learning suturing skills on a banana is feasible for graduate students. And high fidelity is extremely complex. And the question is, how can you assess this fidelity levels? And we developed a framework to assess fidelity of many simulators. And if you look at the previous used simulator, in this case, the Orpheus perfusion simulator, and look closely at the fidelity aspects, we will define it as mid-fidelity. And actually, there are no high-fidelity simulators available related to cardiopulmonary bypass or ECMO use. So how to move forward for MiEC? Well, I think there are a lot of relevant scenarios to improve decision-making. Great examples already exist for scenarios regarding, for instance, air embolism. But the question is the problem communicated adequately to the team, to the perfusion team, anesthesiology team? Is there a correct response? Is the patient put in Trendelenburg? Are the cannulas clamped? How is the debriefing? Is there safe communication? So I feel that there's an enormous potential for MiEC. So I feel the future of MiEC or MiEC-like practice is to train before actual practice on patients. And I foresee a new dogma for heart surgery. See one, simulate one, do one, and teach one. And with that, to decrease MiEC learning curve and remove barriers to MiEC or MiEC-like practice. But we have to develop MiEC simulation-based training. And the question is, what do we need? We have to conduct training needs analysis. Which aspects of MiEC practice do we aim to improve? And how to assess the impact of simulation-based training on MiEC. And we have to use the expertise that's available in societies. EACTS is building up expertise with the Society of Simulation in Europe, but also EuroELSO where expertise is available. So for me, this is the future of MiEC-like practice, the way forward with simulation-based training. And with that, I'd like to thank you for your attention, and I'm open for discussion.
Thank you so much, Professor, for this impressive presentation about the training. I believe that is the future of perfusion in all aspects and in all procedure. There is the question from the audience or our panelists, please. No, I have a question for you. Do you think that in the context of MiEC, in the multidisciplinary approach, not only for the perfusionists, improve the technical skills, in particular in the management of the volume of the accident during the MiEC procedure, in your experience?
Yeah, I think MiEC is maybe one of the best examples of team training. Where the balance for patient safety, the essentials are in team efforts. And I think the whole team should be trained. So not only on these technical aspects, how to handle from the perfusionist side, but also on volume management sides, the Trendelenburg position, etc., but also on communication. So are the problems perceived, communicated? And I feel simulation-based training is the way forward. to train teams adequately for emergency situations and for MiEC as general training. Absolutely, yeah.
Thank you, Professor. If there aren't, okay, from Michael Vondriel, please, you come. Yeah.
I'm afraid I cannot hear the question.
Yes. Will arrive. It's a problem of microphone.
Okay.
Yeah. You come from the podium, no problem, please.
All the way from the Netherlands.
Yeah.
Good morning. Can you guys hear me? Oh, perfect. Okay. Hey, there was Frank. Thanks for that presentation. I think maybe one thing to add to this is that the difficulty with simulation is always training the entire team. But what we have seen that's been effective is at least using some of the training equipment that's already available on the market, like Califia is a good example. In the absence of being able to find a successful way, short of actually doing an animal, to be able to train the entire team on mini bypass or with MiEC, honestly, there are other technologies available that are not a bad substitute, especially for emergency training. I just wanted to maybe get your perspective on that kind of technology, but also what else needs to be done beyond that, beyond the technology that we have now. What else would we need? Thank you.
Absolutely a valid point. So I would say two aspects. So I talked about low fidelity, mid fidelity, high fidelity, and I feel that for several aspects, so first getting the knowledge right of the, let's say, everyone in the team, you can do it individually. You can train the skills individually. You can scale up, going to more complex situations in the OR, in a simulated operating theater. And I think in the end, we have to get teams together. If you want to perform MiEC, if you want to perform high-level surgery, simulation-based training is just as important as doing a timeout, right? So we have to allocate time. The question is how to do it. It goes beyond this talk. We assessed 30 simulators, Khalifa as well, other ones. I feel there's a need to make a high-fidelity simulator to be able to simulate all aspects of MiEC or cardiac surgery in general, which is not really out at the moment. There are simulators available for a lot of components, fully agree. But I think we have to develop this. And there's a disclosure from my side that we are developing such a high fidelity simulator at our university at this moment. Yeah.
Thank you very much again. Thanks, Frank. For the sake of time, I think we'll move right into the next session here, which will be from comics to MiECs. And I'll let Dr. Merkin and Dr. Anastasiadis come up and moderate those.
The pressure of time, we will proceed to the next session, which is actually one of the most important topics for the society. We are discussing about randomized control trials, and actually we are in the process of publishing result to the biggest trial ever in the topic. 1,057 people randomized into conventional versus MiEC systems with comics trial, which will be presented to you by Professor Andonitsis. And of course, the trial that has succeeded this MiEC trial which we have now, as you will see, 130 patients out of 1,300 that is designed to have, that is 10%. So both of them are, for us, very important to give evidence, because after this we will have class 1 level of evidence A, and that would give maximum input that we could give as society to people that they need data. So sufficient data is there, and I hope we will be able to accomplish both of these goals in the next couple of years. So John,
Yes.
can you present polychronis and take it from here?
Yes, so I think now I have Professor results from the sorry, thank you. Yeah, so Professor Antonitsis will be giving us an overview of the results of the COMEX trial and a preview of the upcoming MiECTiS trial.
Okay, thank you very much for coming and joining MiECTiS anniversary meeting. So I would like to show you the transition from COMEX to MiECTiS. Okay, so COMEX at first was a large randomized trial that was designed in 2017. The first patient was recruited on May 8, 2018 in Thessaloniki. These are the landmarks. 14 centers participated. It is the largest study on cardiopulmonary bypass. And actually, COMEX was launched after the position paper produced in 2015 by the society, by the MiECTiS, actually defining what is minimal invasive extracorporeal circulation. This was a multi-center effort, a multidisciplinary effort, and this position paper was actually proposed by surgeons, by anesthesiologists, and by perfusionists. So the conditions were mature, the conditions were ready to really perform a study on minimal invasive versus conventional cardiopulmonary bypass. It was designed the protocol was designed by Bristol. The aim was to test the hypothesis that MiECTiS is effective and cost-effective compared to conventional extracorporeal circulation to most cardiac surgery operations. And actually, it was designed to estimate a difference in a primary composite outcome and 30 days postoperatively, and the cost-effectiveness of MiECTiS as well. The types were used were type 2, 3, and 4 as defined in the MiECTiS position paper. And also, there was something important. There was the conventional circuit was not actually conventional. We gave the opportunity to be optimized. So apart from the conventional circuit, one center could add a coated oxygenator, could add coated tubing, could add a centrifugal pump, but it was not allowed to use a soft shell reservoir or vacuum-assisted drainage, because these components actually make conventional resemble to minimal invasive extracorporeal circulation. So it was real world. The primary outcome was composing of 12, let's say, hard endpoints: death, MI, intubation, tracheostomy, gut infarction, prolonged mechanical ventilation, stage 3 acute kidney injury, stroke, reoperation, need for coronary for percutaneous coronary intervention, sternal wound infection, or septicemia. And secondary outcomes were blood products transfused, ICU and hospital stay, other serious adverse events, and quality of life. So the statistical sample analysis showed that in order to have a 90% statistical power, we had to randomize 3,500 patients to detect a difference in 25% in the primary outcome. The expected rate of the primary outcome was 15 to 18%. And we were expecting a reduction of 25% in the minimal invasive extracorporeal circulation cohort. So through these years, we managed to randomize 1,071 patients with a rate of about 25 to 30 patients per month in the good months. And this was actually related also to the COVID pandemic that actually exerted a very, very great pressure to the study. Also, what we saw is that the primary outcome rate, as I told you, instead of 15 to 18%, it was around 10%. So these are the final arms of the COMEX study. 536 versus 535 patients were analyzed for the primary and secondary outcomes, and the result was that there was a significant 25% reduction in the incidence of the composite primary outcome. So as you can see, this was statistically significant with a p-value of 0.025. Combining all-cause mortality, serious adverse events, and all the events that comprise the primary outcome. Regarding the other outcomes, there was no statistically significant difference, either in ICU stay or hospital stay. And if we see the numbers, then we find that the primary outcome event was 13.2% in the conventional extracorporeal circulation cohort versus 9.7% in minimally invasive extracorporeal circulation, which gives a statistical significant difference. We calculated red blood cells in terms of patients transfused and not in units transfused. That's why there was no difference in patients in the rate of patients transfused in both arms, either in red cell transfusion or in other blood product transfusion. Otherwise, regarding the quality of life, there was statistically significant difference in terms of the visual analog scale, EQ5D score. Okay, so at 30 days and at 90 days, minimally invasive extracorporeal circulation, let's say, was really associated with a significant improvement in quality of life. There were some issues in this study that need to be addressed and have been extensively discussed. First of all, regarding the arm of minimally invasive extracorporeal circulation, a significant percentage of patients randomized to MiECTiS did not receive the alternative allocation. The analysis is always intention to treat. So even if you receive an alternative allocation, the statistical analysis needs to include you to the arm that you have been initially randomized at. So these patients were randomized as MiECTiS and analyzed as MiECTiS. There were some other deviations from the protocol. I mean, 9 out of 500 patients, a roller pump was used with MiECTiS, which is actually a deviation because MiECTiS should include a centrifugal pump. Also, we found that in patients randomized to minimally invasive extracorporeal circulation, a huge proportion of patients had the cardiotomy suction used. So there was actually a mixture of shed blood to the circuit that actually makes the circuit not completely, not 100% closed. And also, you can see that COMICS trial produced a significant difference in the need for transfusion intraoperatively. So 21.7% of patients in the conventional extracorporeal circulation required the transfusion intraoperatively, while 12% of patients required an RBC transfusion intraoperatively in minimally invasive extracorporeal circulation. But as I told you previously, the total incidence of patients transfused was not statistically significant. And this was because there was not a uniform blood transfusion protocol. So that means that within the next postoperative course of the patient in the ICU, there was, let's say, a diffusion, a minimization of this optimal outcome produced during surgery, okay? So as the centers had a liberal protocol of transfusion, this led to a total of patients transfused, the total rate of patients transfused to be the same, while there was significant difference in the patients transfused intraoperatively. Regarding the primary outcome events, we will see that with minimally invasive extracorporeal circulation, the rate of the primary composite outcome was low, but it was actually minimal. So it was 0% stroke, it was 2.5% of reintubation as compared to 5% in the conventional arm, and also the incidence of sternal wound infection or septicemia was actually very, very low as compared to a higher result as related to the conventional extracorporeal circulation. So this study has important strengths and important limitations. The strengths are important. The study is pragmatic. There are different minimally invasive extracorporeal circulation systems. It's real world, and it is compared actually to optimized conventional cardiopulmonary bypass and not the standard cardiopulmonary bypass. It is a multi-center study. It is a clinically important primary outcome, and also it addressed all limitations of previous randomized studies that were not considered, that were considered to have a significant risk of bias. So actually, all measures to avoid bias were taken for this study. And avoiding bias is a significant strength of the study. The limitation is that the planned sample size was large and it could not be achieved during the COVID period. So with a statistical power of 90% during the COVID pandemic, in order to randomize 3,500 patients was not possible. We also found a reduced incidence of primary outcome. If the incidence of primary outcome was 10% instead of 15 or 18%. So this says that the surgery, let's say, was better than expected. Yes, that's correct. Maybe 85% of cases were coronary cases, so there should have been a mixture of more difficult cases in both the conventional and the minimally invasive extracorporeal circulation arm. Second, optimized extracorporeal circulation was used in a significant proportion of patients, okay? So including centrifugal pump, coating, and cell salvage was used in a significant percentage of conventional extracorporeal circulation. Also, perfusionists followed goal-directed protocols that, let's say, reduce the incidence of adverse outcomes. And regarding the secondary outcomes, as I told you, the analysis of blood transfusion was based on blood products used. So even if one patient received 1 unit of blood one night in the ICU by the attending physician, this patient would count as having a blood transfusion at the same level as the one who had 10 units of blood transfused. So we didn't focus on volume or units of blood, but we focused on either the patient was transfused or not. And this actually underestimated the benefit that we have found on the intraoperative use of blood products. Okay, so the intraoperative benefit, the benefit was lost. And also, as Dr. Elezawi is always pointing out, using a cardiotomy suction and mixing and said blood with the circuit, you actually lose this closed circulation, this closed physiology benefit of minimally invasive extracorporeal circulation. You increase the possibility of having a systemic inflammatory response, and this correlates with outcomes that are related to systemic inflammation, like atrial fibrillation, and also it relates to blood transfusion and all that. This study, I believe that within the next month will be published in Perfusion Journal, and we will have the time to discuss it further in multiple instances. So now we're in a crossroad. What shall we do? Is it better to stop? It's always better to shine a light than curse the darkness. So it's always better to do something rather than do nothing. Okay, so there is no need to curse the results rather than learn from them, but we need to avoid using the same old thinking because we will produce the same old results. And as Ashraf Elezawi and Einstein telling, it's not good to do the same thing over and over and expecting different results. So from comics, MiECTiS study was born. Okay, so it's a randomized controlled trial that, let's say, follows the same pathway, but addresses main limitations of comics trial. So first of all, we need to all agree with this thing. Conventional cardiopulmonary bypass, we can never say that conventional cardiopulmonary bypass is not safe and effective as MiECTiS. In the real world, conventional cardiopulmonary bypass with, let's say, the Quantum heart-lung machine or the Livanova Essence heart-lung machine is absolutely safe and effective in performing all types of cardiac surgery. So this is a fact. What are we aiming to do? And this is reflected in evidence-based guidelines concerning minimally invasive extracorporeal circulation. We want to make it more physiologic to reduce the incidence of adverse complications. So is MiECTiS a better perfusion technique compared to conventional cardiopulmonary bypass? In which terms? In terms of reducing the incidence of perfusion-related complications and not surgery-related complications, as it is the postoperative myocardial infarction. If you have, let's say, a compromised, not so meticulous technique in coronary surgery, a graft failure, then you will have an MI. So it's not related actually to perfusion. So we will test the same hypothesis again, that compared to conventional cardiac surgery, minimally invasive is effective in reducing a primary outcome, that this time the primary outcome consists of heart endpoints, death, type 5 MI, stroke, but also acute kidney injury of all stages, not stage 3, that is hemodialysis. All stages acute kidney injury. Mechanical ventilation for more than 48 hours is a very delicate marker, and it's considered by the STS as a marker of something that happened during surgery, rate of reintubation, of course, rate of reoperation, and septicemia confirmed by microbiology. While secondary outcomes will include blood products transfused per unit, not patients transfused, blood products transfused, incidence of postoperative atrial fibrillation, ICU and hospital stay, other serious adverse events, and health-related quality of life. Why any stage acute kidney injury is important? It is important because even if you see studies evaluating studies that evaluated outcomes after cardiac surgery, like the Title II trial, which focused on blood transfusion after cardiac surgery, you can see that during cardiac surgery, we can expect a rate of at least 14% of any stage acute kidney injury. Okay, so this study that consisted of 40% coronary cases, at least a 14% of any stage acute kidney injury was evidenced during cardiac surgery. And even in the ARC trial that actually compared a single mammary versus bilateral mammary in coronary cases, you can see that the most frequent complication was acute kidney injury that was found in 17.4% of patients. Okay, so this is an incidence that is related to perfusion. Why it is related to perfusion? Because if we see the results of Ranucci's GIFT trial, goal-directed perfusion, he found that with goal-directed perfusion, with the optimal perfusion strategy in terms of providing metabolic substrate to the tissues, what he could find, and he included 24% CABG patients, was that the main difference was reflected in the acute kidney injury of any kind. So in the arm not using goal-directed perfusion, he found a 25% incidence of acute kidney injury, while in the patients that he did goal-directed perfusion, as is the case in our study, because as you have shown in the previous study, the centers used delicate perfusion, optimized perfusion circuits, and optimized perfusion techniques while randomizing patients. So he found with goal-directed perfusion an incidence of 15.4%. So we actually included any kind of acute kidney injury as a primary outcome in our study, and we opt for including 50% of coronary cases and 50% of aortic valve cases or combined cases in order to increase the complexity of the surgery and not including, let's say, straightforward coronary cases. And with having an 80% statistical power and expecting an outcome with very, very, very conservative estimation of 20% of the composite outcome, you saw that acute kidney injuries from 15% to 25%. So expecting a 20% incidence in conventional extracorporeal circulation, expecting for a 30% reduction in primary outcome, we need now to randomize 1,300 patients for the study in 2 arms of 650 patients. How can a center can take part? A center can take part if using MiECTiS for 50 or more operations, operations of the type of which participant is being recruited, and this is the learning curve. So the learning curve for MiECTiS is 50 patients. Eligibility criteria are very, very liberal. So actually, patients could be randomized if they are over 18 or less than 85 years old, mainly without having an emergency surgery or aortic surgery or having a hematology disease that could actually mix the result and, let's say, underestimates the benefits of minimal invasive extracorporeal circulation. Trial intervention will be the same. So actually, optimized conventional extracorporeal circulation will be accepted. Okay, so coated oxygenators, coated tubing, and centrifugal pump could be integrated into the conventional circuit. Full sternotomy, surgeons must use the same body temperature and cardioplegia solution. And also, let's say, learning from comics, we applied a transfusion threshold. So we applied a transfusion threshold either intraoperative directed perfusion intraoperatively, a DO2 index of less than 2.80 or an oxygen extraction rate of more than 40% gives the perfusionist, let's say, the signal to transfuse the patient. So as far as today, we have recruited 130 over 1,300 patients, and this makes a 10% incidence, and 40 patients were recruited from Thessaloniki, 31 from Ulm, 10 patients from Bari, and 49 patients from Izmir, Turkey. And the case mix, the same again. Most cases are coronary cases, and we expect to have more valve, aortic valve, and combined cases in the future. Is it feasible? It's feasible if we increase a little bit the recruitment range. So if we manage to do at least 30 patients per month, it is feasible within 3.5 years to conclude the study. I believe we can achieve even for more. The study is not designed by Bristol, it's designed by Aristotle University Clinical Trials Unit, and the major investigators, apart from Professor Anastasiadis and me as a study coordinator, it's Andreas Liebold and Prakash Punjabi, Sardar Gunayuddin, Asraf El-Ezawi, Cyril Serik, and every center is allowed to be registered as an investigator in the study. It's important that we have with us clinical dendrite system registry, which is a very, very experienced and very, very easy to use registry to put the patient data in. It takes about 20 minutes to get the patient's data in, and it's simple. It's the perioperative 30 days period with data that you have inside the notes or in the clinical system of the hospital. You don't need writing at all. There is a trial steering committee with the president of John Merkin, and data monitoring committee with professors from our university. This is very, very experienced committee. And for the time being, you see the 4 centers, but I hope that Toronto, it's Brian here, will start soon, Ankara, Papworth, Hammersmith and Hull, Braunschweig and Göttingen from Germany, possibly Cosvik, Ancona with Dr. Deusanio and Pietro Malvidi, and possibly Regensburg could contribute with cases. If we achieve 10 or 12 centers, that would be great. So the message of this presentation is join us if you can. If you cannot, try to change something and join us as well. Okay, thank you very much for your patience, for your attention.
Thank you very much. And I think the panel will be making some commentary on the results.
Let's start one comment each because we don't have that much time. So all together, either for comics or for MiEX, a comment from all the panel. There is online commentators as well.
Well, I only have one comment. I think that one problem in doing a large prospective randomized trial in such a setting is that you have to get a lot of participants into the boat. That leads to the fact that you make some compromises. I think that we have learned a lot from the experience of the comics trial, and I hope that this will reflect in a more powerful MiECT trial.
So we really need a large data to publish and to increase the level of evidence or the class level in guidelines. So this will be a very good opportunity. In Turkey, as Youssef presented before, in the last year after COVID, there was a time that we couldn't even find the oxygenator. So people were forced to use MiECT. So this was not a voluntary choice, but so that's why there were 18 centers and now 8 centers, but still we need to motivate them. So I believe Istanbul is also going to participate. They're doing nearly every case by MiECT.
Yes, I believe that it is really important to collect the data, analyze the results of MiECT. I believe that it is important improve the post-operative management of the patients underwent MiECT. That I think that the principal limitation in the hospital today is that there are low, highly professionals with high turnover in the management of the healthcare of the patients. It's possible to see that anesthesiologists in the middle of the night change the protocol. I believe that only one limitation is that improve the post-operative practice in the MiECTiS strategy. But nevertheless, I think that is a good way in my perspective.
Thank you, Brian.
So we are about to start participating in Toronto. I was speaking to a surgeon before I left, actually, and we have our first few patients kind of lined up for the 3-week out mark. So we're about to start performing the trial on them. It'll be interesting to see if we can stick to that transfusion trigger. To Ashraf's points, there's a lot of hands in the pot when you do a big trial like this. So I think it might be difficult to stick to the transfusion trigger. Is there a way that in the dendrite system that we're able to audit that, like when a transfusion is given, if it adhered to that trigger?
Yes, of course, you can actually have a liberal policy on transfusion. We will record that. Okay, so you're free to transfuse, but try to keep the protocol. We record the HB level when transfused, but we try to keep it at a level of 8. Otherwise, the results are largely diffused. So you see that we lost a significant advantage of reduced intraoperative transfusion by letting 14 centers transfuse without having a certain, very, very liberally. Okay, so we will record it, you will record it, and possibly in a secondary analysis, we will say that we will see whether this affected the transfusion rate or not. Okay.
Okay, yeah,
Okay,
good.
so
Yeah,
of
we
course
will
the
do our
frequency-
best as long as we can track if there are any outliers that occur.
Naren, before you comment, there is one comment from me to you. As you know, UK is quite active in mini bypass in MiEC, and we would like to have all of you on board. Unfortunately, Prakash is not, and Alex Kale is not joining, so you are the UK representative. So I would like to say that despite a lot of efforts that Polychronis has done so far with Imperial, that is leading to have the final verdict from your, I don't know, it is an insurance issue or whatever it is, we still struggle to have UK on board. And I can tell you that Canada, as we discussed yesterday, they have the same NHS with you. I mean, the healthcare is about the same. So since you have Canada's permission, I believe that it won't be that difficult for UK to accept that insurance shouldn't be the case, because for the rest of the people that they don't know, this is not a sponsored trial. So we don't have either fund or sponsoring. And that's the issue for the UK guys that say, okay, what will happen for our patients? So Naren, Brian is here, Bersto, and you can ask him how they managed to get the permission. So what about you? What do you think?
First, thank you. Welcome. Nice to see you all, and fantastic conference. And thank you for inviting me to talk. Specifically, just to comment on the two trials. The data is powerful. It's still needed to change mindset and to deliver the real change we want in clinical outcomes. So fantastic results from COMET's MiECTiS trials still needed. I echo the points that have been made already about learning, transfusion requirements. The patients are allocated one onto the other is a big issue in the use of cell suckers during the mini bypass set, and specifically the changes that outside the operating room. I think those are all crucial points, and they need to be addressed and are being addressed to make sure the trials show some valid results. To answer your last question specifically, it's not necessarily the insurance, it's the funding. Most of the departments that I've spoken to, and I've spoken to Prakash offline, Polychronis is doing a fantastic effort, and he's been pushing us all. Our department specifically, it's about funding, and I know that's the same with Prakash. And so finding sponsorship or ways around that is what we're trying to do. But because since COVID, our R&D departments are swamped with different studies, they will only take on ones that are funded, and that is the biggest challenge.
Okay, thank you, Noreen. Is there any question from the floor? Because we're running a bit late. Okay, so John, would you close it with comments regarding comics and MiEX? You are the senior guy, you are the chair of the steering committee of MiEX.
Yes.
And you've been one of the authors of the comics paper. So
Well, I think again, as we're all commenting, one of the real benefits of the MiEC trial is the fact that we have gone through a rather challenging process, as you've heard, with the comics trial, and so based on those results, we've been able to identify some of the rate-limiting factors and some of the missed opportunities, and I think. The fact that we will look for rifle one criterion, so changes in creatinines and renal performance rather than having a hard endpoint of dialysis. I think again what we're trying to do is identify changes in organ function. So rather than waiting for an extreme endpoint such as dialysis. In fact, we can have a more sensitive measure, and similarly, the big confounder of patients having no real adherence to the restrictive guidelines for postoperative transfusion also confounded the results. So I think the ability to focus on these aspects and hopefully minimize them in the upcoming trial are important learning factors. So.
Okay, so thank you all for this session. I hope we'll be able to publish very soon, maybe next month, and you will have the full paper. And we are proceeding for the next session, which is the mix on MiEC with Vadim and Ashraf.
So, welcome everybody to this session on mix on MiEC. Our first presenter will be our new president of the society. I think this is your first lecture as president, so it has to be a very good one. Professor Gunaydin, who's been active in both MIX and MiEC for over a decade now, and he'll report on his experience.
Thank you very much. So I'm going to start with the discussion of the maybe the future of the use of MiEC because, you know, minimally invasive cardiac surgery has become very much popular now among cardiac surgeons. So this will be a new area to combine MIX with MiEC. So I am a cardiac surgeon in Ankara, Turkey. I also have a PhD in bioengineering, and so I can usually do research on both sides, clinical and preclinical. So as you know, just most of those topics were discussed here, the disadvantages of the current conventional systems, but as also been noted, they're also being optimized in some ways because, for example, when I started research in the early 2000s, we were comparing coated versus uncoated circuits. I don't believe there is any uncoated circuits anymore. So centrifugal pumps are becoming more and more popular. So they're kind of, I believe in the future studies will be comparing a MiEC versus optimized circuit. So this is the video from the years 1950s, the early phases that was shot in Holland. They were doing research on cardiopulmonary bypass devices. And these devices were being used, real cardiac surgery at that time. So it's only about 70, 65 years and that may show us how much we evolved. So this is a simple design. And this is the pump heads and the real one. You see, patients were operated on these machines in about 50, 55 years ago. So we really come a long way. I cannot show you all the video. So we start with the conventional systems, minimize simple, that's type 1, go to some kind of support, and come finally to the modular CPB. So this is a drawing by Dr. Kyriakos and friends. As you can see, minimized circuits is a very simple way of using, but have very really clinical results. So after it's become a kind of modular system, the areas of use and indication have become wider. So we use it now in any type of limb perfusion in emergency unit. With just help as for TAVI procedures, some oncologic applications, bridge, and some transplantation. So many new places. And the evidence level is now around 2A, and I believe after the publications we just discussed will be higher. So we initially started comparing those types of circuits very early in the years 2007, 2009, and even we compared the gaseous emboli detection systems at that time. So this is a design. Yeah, this is our own design. It's patented in US and in 1999. And then we compared the gaseous microembody detection systems at that time. So we even compared in our studies with minimized circuits versus beating heart, and it's not inferior to the beating heart. Even in some parameters were much better. And of course, we just have a position paper, the COMICS trial, and this is the circuit we are using right now. It's a Livanova circuit. Sometimes changes, we cannot find the product. So basically we are using like type 3, type 4 systems right now. So minimally invasive cardiac surgery have become very much popular, especially in the recent 5 years. Even in Turkey, maybe more than 10 years now, it's been very much popular. So for example, with respect to the numbers in Europe, the incidence is about 20% up to 45%. But you know, it's the opposite. The use of MiECTiS is around 4%. So there is a lot of difference in between them. In order to, the title is two peas in a pod, we have to combine them. And so it's a kind of innovation. It's kind of, you know, a supply demand issue. So the patients are demanding this. So that's why we need to, let's say, optimize our ways of surgical approach to help them have some better clinical results. So what's the disadvantage? What's the challenge of the minimally invasive concept? So as you can check all of the guidelines, so still very, very limited information about minimally invasive cardiac surgery. I've even been in guideline committee in STS last year, and we discussed 2 hours, and they finally decided not to give any class or recommendation for minimally invasive surgery. We were discussing the guidelines for perioperative bleeding, and they didn't include minimally invasive cardiac surgery because they say we are not satisfied with the publications of minimally invasive cardiac surgery. There are lots of publications, but the same story, like 20 patients, 30 patients, very, very much different techniques, very much different incisions. So it's not easy to compare to have a clear idea, even in the minimally invasive cardiac surgery. And the main concern is, of course, always is the longer CPB time. Because when you start minimally invasive cardiac surgery, it's sometimes 2 times or 3 times more than a usual open cardiac case. So that, of course, influences the outcomes, like respiratory support time is longer, hospital stay is longer, and so many, many other disadvantages. And so, as I told you, so with respect to the guideline, so it's okay. So 2A for minimally invasive circuits, but for minimally invasive cardiac surgery, not easy. You cannot find very clear guideline to underline this minimally invasive cardiac surgery. Let's say 2A or 1A. So it's a kind of preparation is very important. Right now in our clinic, we are doing nearly all valve operations by minimally invasive techniques, and nearly half of the coronary bypass surgery by mid-cap surgery. So of course, it is different perfusion techniques, different cannulas you need, different surgical instruments. This is the most challenging one. And you need to prepare patients preoperatively by CT scan, 3D visualization, and something like that. So it's a challenging business to prepare the patients for minimally invasive surgery and to decide that this can help the patient. So crest clamp time is longer, cardiopulmonary bypass time is longer, operation time overall is longer. These are the studies, meta-analysis right now. And of course, the ventilation time is longer. So that means the length of stay is longer, and incidence of myocardial infarction is 0.35. So the difference. And some stroke and neurologic complications are not different, 0.66 with respect to this meta-analysis. So as a result, this meta-analysis says minimally invasive cardiac surgery has significantly shorter stays in the ICU compared to those operated on conventional median standard. But this is the only outcome this can say, but of course, it is like 0.036. It's a very, very, let's say, slight significance. And again, you can see many other papers. This is the longer CPB time significantly. And of course, this is the right question. Do we have enough evidence for minimally invasive cardiac surgery? Then you can see here the comparison of those with positive and negative aspects. As you can see, not much difference. The clear difference, it's aesthetic for patient, okay, but very, very difficult for the surgeons, especially in the beginning phases. So for the mid-cap, it becomes even more challenging. So the first, let's say, mid-cap-like CABG surgery was performed in 1998. So it has a long story indeed, but it becomes much popular in the last 5-10 years, we can say. So there are some contraindications. For example, you have to evaluate the left ventricle, the sizes. So you need a very good echocardiography. And of course, this is a chance. We do everything to evaluate before surgery, but still we see intramyocardial coronary vessels during the operation, and it's a mess. It's a very difficult one. So for relative contraindications, of course, morbid obesity, some pulmonary disease because single lung ventilation is needed. And again, the left ventricular sizes. But of course, the patient comes to you, let's say 150 centimeters with 100 kilograms lady says, I want to have a mid-cap. So this is the more challenging part. You need very, very specialized equipment for EMA harvesting, for some other retractors. So this is difficult to have the whole setup. And of course, there are some meta-analysis for the outcome analysis of mid-cap. And again, not inferior to the conventional technique, but again, not clearly positive outcomes. And again, the most important problem is the longer CPB time that may affect the patient. And of course, when you combine, I will describe it later. So this is the clinic advice. Okay, mid-cap has less scarring, shorter length of stay, less pain. I don't agree. Quicker recovery, a lower risk of AFib in some studies, and generally most activities with few limitations. So as I've told you, we start like about 6-7 years ago and started doing all valves now by minimally invasive techniques. And we started mid-cap like 4 years ago, and now half of the coronary operations are done with the mid-cap incision. But we really spent nearly 1 week to understand if we're going to do this operation or not for the patient. So for example, this is CABG ×4, and this is the incision. So we also published some kind of reports in some congresses. How about to combine them? So of course, this was the real target for us, and we really combined them. And then we were very much afraid for the venous return problem, ventricular unloading, but we really didn't have any of these problems. We were surprised that we didn't have in those problems during our early mid-cap experience. So we did about 10 cases, 15 cases in the last 6 months, let's say, and we didn't really experience any problem in ventricular unloading, not different than the conventional circuit. So for MiECTiS and MiECTS, for surgeons, it's very much important that the surgeon should know the circuit he is working with. So he should have some kind of experience with MiECT before. So he cannot say, okay, tomorrow I will start with MiECT on MiECTS. So this is very much challenging. It's very difficult to do. And again, the air is a real problem. So this is the most important problem we were facing with those circuits plus MiECTS. So air handling is very important. And also shed blood, you have to take care of it in some ways. You can do cell saver or anything else. And of course, communication and teamwork. I don't even want to mention it. For the anesthesiologist, again, and kind of experience the anesthesiologist should have. So because the fluid management is very important, and monitorization is somewhat more important in this minimally invasive techniques. And it's very easy to go on the ERAS protocol. I don't say fast track because the ERAS people don't like to say fast track. They want to say ERAS because it's not only fast track. It includes also nutrition and some other pain management. We will discuss it in the afternoon. And of course, if you have a point of care machine, it's much better and easier to use in the anesthesiology side. And they need to take care of some anticoagulation protocols. For perfusionists, it's the same story. They should have some kind of previous experience of MiECT, closed circuit, volume management. And of course, vacuum assist becomes more important in this case. And cardioplegia is a kind of very important thing because you do everything minimal, and then you should also lower the dose of cardioplegia. So if you give, let's say, one single dose of 2 liters, it's not very much logical. So we use, again, mini cardioplegia, let's say, to control everything on mini. So we also published some papers combining these strategies all together with very much better results in valve surgery. And this is the publication we did in the recent symposium. As you can see, we compared the endothelial glycocalyx on the lab. And as you can see, this is the endothelial glycocalyx layer of the mini circuit, and this is the conventional circuit. As you can see, the same glycocalyx already broken. So this is important for the cell function. And aquaporin are some other molecules that controls the volume overload in the cell. So we also compared it on microscopically. As you can see in the conventional technique, this is the post-op. You see the cellular edema very easily, and this is the MiECT, really controls the volume management. And again, we have an active patient blood management program. We have the teamwork. We are doing it for the last 10 years. So we are really good experienced in this case. And in the operative side, we really integrate minimally invasive surgery and also MiECT. And we also have an actively functioning enhanced recovery after surgery program that we are going to discuss again in the afternoon. And again, this is a much more complicated protocol, again, including MiECTS and MiECT in this protocol. So pain is very important. As I've told you, they always say, if you have a mini incision, you don't have pain. I believe it's just the opposite. If you have a mini incision, you have more pain. So we always use some blocks in the preoperative period, and in the after operation, we also put some those kind of catheters to control pain after surgery. So of course, I don't need to conclude about MiECT. So we all know the advantages and disadvantages of MiECT. For MiECTs, yes, it's really a kind of demand issue as far as I believe. Young surgeons and even middle-aged surgeons should know how to do that because It's becoming more and more popular, and there's a high demand from the patients that wants to be operated under these incisions. And the best solution may be to combine these two, because however you are very much skilled and experienced surgeon in mix, the period of cardiopulmonary bypass time is still significantly longer than the usual open one. So in the future of cardiac surgery, we'll be really competing with the interventional procedures like TAVI and newly like a mitral valve, tricuspid valve, anything they do. So we have to find some ways to compete with them, and maybe minimally invasive surgery plus MiEC would be one of the alternatives. So this was the early operating room, and this is the new room. So we are really evolving, and so the surgical techniques are evolving, and the technology will evolve. So the future of cardiac surgery is going to be a kind of combination of innovation and combination of those all new techniques. Thank you very much.
Thank you very much. I have to introduce next presentation because we should run. And next presentation, mix MiEC current evidence, Dr. MiECTiS from Thessaloniki.
Okay, thank you very much. Thank you, Serdar, for this concise overview of MiEC in minimal invasive cardiac surgery. So as I listened to your speech about the benefits for the surgeon, the anesthesiologist, and the perfusionist, and I'm looking at Mike Van Driel, I would say that it's not only these three parts, it's that the patients want minimally invasive surgery at all. The patient wants enhanced recovery after any type of surgery. So in Greece, they ask us, are we going to do it laparoscopically or things like that? So as long as you have the consumer that wants something, then it is definitely something that we need to pursue. Otherwise, we cannot be a scientific society and, let's say, the society that moves to another way. So I will just present you the current evidence, but with this sense, if the consumers want it, the industry will follow, and we need to follow as well. So we have the ISMICS Congress in Athens. I'm just advertising it, and we have to combine minimal invasive cardiac surgery with, to be the, let's say, if this is considered an advance in cardiac surgery, we need to make it even more advanced. So what is minimal invasive cardiac surgery? According to the definition, minimal invasive cardiac surgery, the term minimal invasive refers to a small chest incision that does not include a full sternotomy. This is the case back from 2008. But is this really the case? Whoever met Hugo van der Men, I believe this is the man behind minimal invasive cardiac surgery. He invented minimal invasive cardiac surgery in the era of conventional cardiac surgery. And he wrote in 1998 that the objective factors affecting the degree of invasiveness are the surgical approach and cardiopulmonary bypass, and that comfort and cosmetics may also be improved. But this is this truly minimal invasive cardiac surgery? He was asking back in 1998. Or is it simply fashionable minimal invasive cardiac surgery? So he said that minimal invasive cardiac surgery is cosmesis, alternative access, plus cardiopulmonary bypass. But as you see over the years, this part was excluded, and we actually focused on an alternative approach. The message, the clear message of this speech is that minimal invasive cardiac surgery without minimal invasive extracorporeal circulation could not exist, as Hugo van der Men was implying. So in order to provide the best care for the patients that the patient requires to have minimal invasive surgery, yes, with a better outcome in terms of enhanced recovery, we need to provide minimal invasive cardiac surgery with minimal invasive extracorporeal circulation. You can't have one without the other. That's why perfusion matters, and it will always matter in cardiac surgery because it's related to any type of cardiac surgery, and it is related actually to the complications that we see after surgery. The need to perform minimal invasive cardiac surgery actually promoted the optimized perfusion circuits. I mean, in terms of changing cannulation strategies, so moving from the central to peripheral cannulation, changing aortic cross clamping, adding vacuum assisted venous drainage to perfusion, a little bit, changing myocardial protection from blood cardioplegia that we all know it's better to the Brett Snyder cardioplegia that we all know it is not the best, but it suits to the minimal invasive cardiac setting. So we started to doing modifications to apply to minimal invasive cardiac surgery. And as Dr. Gunayudin pointed out, we have increased cross-clamp time and cardiopulmonary bypass time in minimal invasive aortic surgery and in minimal invasive mitral surgery. Is this important? Yes, it is. As you can see in this study that was published a few months ago, aortic cross-clamp time, the minimal invasive cardiac surgeons say that aortic cross-clamp time correlates with mortality in mini-mitral international registry. So they themselves say that as we increase the cross-clamp time, we increase mortality. So this means that we do not need only to change the access, but we need to improve physiology and perfusion in order to have good results with minimal invasive cardiac surgery. Otherwise, something is missing. Okay, you can see that by increasing cross-clamp time, mortality is increasing. That's why MiECTiS was actually incorporated even from 2011 in the consensus statements for minimal invasive cardiac surgery, because it will further improve, as you can see, ventilation time, ICU stay, postoperative delirium, red blood cell transfusion, as we earlier discussed, and actually it provides a more physiologic environment. This was evidenced by many studies. So especially in terms of neurologic protection and reducing blood transfusion, MiECTiS significantly assists minimal invasive cardiac surgery, even robotic total endoscopic coronary artery bypass grafting. I do not want to go into details. Okay, so these go together. So while we need to implement these ultra fast track protocols that we definitely say that the patient wants, which are the 4 pillars that Ancona is suggesting? Reduced chest incision, this is 1. Rapid deployment, let's say valve, it's the 2. MiECTiS is 3. And fast track anesthesia and ultra fast track anesthesia and recovery is the 4th pillar. But if these 4 pillars, when combined, lead to a better outcome, we need to have why each one of the 4 pillars is good. I mean, if the rapid deployment aortic valve replacement is good, it's not only good because it's in the setting of minimal invasive cardiac surgery. So the rapid deployment AVR, is it good for every case? Or we just use it only in these situations? So that's what I'm going to tell, that we need to implement the best features in every discipline in order to have the best result. Okay, in order to have the patient 4 hours after surgery doing physiotherapy rather than being intubated. And the critical component of the Ancona group in CPB management is enhanced use of minimal invasive extracorporeal circulation with these procedures, and in terms of reducing complications rate. So integration of MiECTiS to minimal invasive cardiac surgery transforms it from a limited access surgery to a more physiologic cardiac surgery. And this is what the patient needs, and we need to adopt it with the assistance of the industry in order to perform, in order to achieve this. We have seen this, actually, these quotes by Bob Chiai in yesterday's presentation, but minimal invasive cardiac surgery and minimal invasive extracorporeal circulation go together. We need to change the conduct of surgery. That's correct, and we have to work together to have the better outcome. That's also correct. So actually, as you can see, minimal invasive cardiac surgery has a pillar of access, a pillar of technology, and a pillar of technique, and the same applies to MiECTiS with the circuit, with the peripherals, and the strategy of goal-directed perfusion and point of care that we have extensively discussed yesterday and today. So all these contribute to the surgery that the patient wants. The patient sees the incision, asks for a limited incision, but he actually asks for a limited derangement in his physiology and not only for a limited incision. This was actually reflected in our position paper, that integration of MiECTiS advances minimal invasive cardiac surgery. So the modern operating theater, this is our operating setup, will consist of the surgeon that is doing minimal invasive cardiac surgery, let's say for a limited incision, the anesthesiologist who will do enhanced recovery, including the whole protocol from preoperative management to nutrition, the perfusionist who will do minimally invasive cardiac surgery, applying minimally invasive extracorporeal circulation, applying goal-directed perfusion techniques and monitors everything. And this is actually physiologic cardiac surgery, okay, with MiECTiS and MiECT liaised one with the other. Thank you very much. This was a clear message.
Thank you very much, Polychronos. We agreed that we'd keep the discussion to the end to see how much time we still have left. So it's an honor to introduce the next presenter. He's Pascal Starinieri, a perfusionist from Hasselt. He's working in a team that has been dedicated towards minimally invasive cardiac surgery and combining them with MiECTiS. Unfortunately, we'll see a pre-recorded presentation. And I would ask for the presentation.
Good morning to you all. First of all, I would like to thank the organizing committee to give me the opportunity to talk about MiECT in combination with MiECTiS, and also my apologies that I could not be present there in Thessaloniki. So MiECT and MiECTiS, a challenging approach. To start, we also all know the classes of recommendations and also the level of evidence. So I was glad to see that MiECT was integrated or mentioned in the CTS and EBCP guidelines of 2019. As mentioned, MiECT, let's say, should be considered to reduce blood loss and the need for transfusion, and also to increase the biocompatibility of ECC. So in our center, we use two types. We use a type 3 for all closed cases and endocabbage cases, and also partial stenotomy AVR together with a pulmonary artery vent, or we use the hybrid system with a pulmonary vein vent, and then meaning mitral cases and also thoracoscopic AVR settings where you have a pulmonary vein vent which is connected to a dual chamber reservoir at the side and two small tubes going down, so you have a small blood gas blood air contact here. We also have the EVO below here, because if you have venting blood, you need to give it back to a steady state. So we position then on certain percentages the EVO, but it will become more clear during this presentation. So safety mechanisms, which I was very keen on to use them starting, I think 10 years ago now, or 9 years ago, MiECTiS in our center. So we started with an SCP. So we had let's say an ECMO console, which has a bubble sensor. Bubble comes in, pump will stop. Then you need to open the clamp, which has all been done manually. Then we had an S5. So we integrated some safety mechanisms, some automatic safety mechanisms, which I will show you now. So we had, or if you have on the S5 or on a different other machine, you have ramp down functions, you have an auto regulation function, you have automatic clamps, and we have also bubble detection. To start with the ramp down function, it's triggered by pressure. So if there is an excessive negative pressure, the RPM goes down to a preset RPM, and afterwards you need to manually increase the RPM. Also be aware of the dynamic filling index. If you measure a -60 negative pressure at the venous line, it can go up to -200 at the inlet of the pump, damaging blood. So also be aware of that. So measuring, not only measuring the venous pressure, but also you need or a ramp down function, or as we do, another regulation function. It's the same. It's been triggered on a negative pressure. So excessive negative pressure, the pump will go down, you give some volume, and then it goes automatically up. It's been done automatically. In the ramp down function, you need to manually increase. In auto regulation function, you don't. So this is a small video. You see excessive negative pressure, and now type 3 in the back, you have one lid attached to the venous line, which you can fill the patient, and the red one, you can empty the patient. In this particular case, we try to fill the patient. You see very negative pressure. You open the tubing clamp, a little bit of volume goes in, so your flow will rise, and also you have back again the steady state. Automatic clamp. We use automated clamps, arterial clamp, and also a venous occluder. So on a bubble sensor, it's been triggered your arterial clamp. So if there is an issue going a bubble, then your arterial clamp will close, so no air will go to the patient, And also, as mentioned before, at the hybrid system that we use below the reservoir, we have an EVO, you have a venous occluder for the venting blood. So venting blood comes inside the reservoir, it gets defoamed, and then you can give it back by the EVO, so you have a steady state. Bubble detection, we have a 1/4 drip chamber. You see here, 2-level sensor are not possible on the S5. So what we did, we kept the level sensor on the VBT, and we go a little bit lower for the 1/4. So aortic needle, aortic bubble comes in, aortic needle pops out, massive air. This bubble will detect the air and it will close the clamp. So you don't have any air inside your system. You put a tubing clamp here, no air, open the clamp, back in business, and you can de-air afterwards to the cell saver. 3/8 air purge control, also bubble comes inside your venous line. It will be detected by the air purge control, and pump will start, and automatically it will remove air. It's a small video for that. See, start of the air purge control, small bubble detected, pump will run, and air with a little bit of volume, it will drawn out and pushed to the back, which you can then reduce the volume. You see here, there is the bubble, and it's been evacuated automatically. Also, as mentioned, the safety mechanisms, we have a 3/8 below here because we switched from the level sensor on the VBT to the reservoir, and if there is a bubble here of more bubbles and your air pressure control can't handle it, it goes here, this will trigger the clamp, so a bubble is not inside your centrifugal pump. This was a little bit, I showed you our 2 systems that we use, but in our particular case, and I think using minimal invasive extracorporeal circulation, type 3 or type 4, you're forced using a certain strategy. And in my opinion, it's a strategy that can work. So in our center, what's our strategy? We have cell salvage to de-air the pump, but also to have separate suction. So at the table, there's only one sucker that goes from the table to the cell saver. If there is a bleeding, in case of a bleeding, we can give a sump, so it can directly go to the pump then. But normally, in 99% of the cases, we do separate suction, so all the blood from the table goes to the cell saver. And normally, we use 225 bowls, and sometimes we have 1 bowl to give back. So separate suction, also coating. We try to do it tip to tip. It's not always possible due to back orders of cannula, so we try to go tip to tip coating. Also NIRS and EEG, we use it in every case, every particular case, especially also in mitral cases when we do double venous cannulation for drainage. If you put a jugular cannula in, that you do not obstruct, let's say, or create venous pooling, which can also cause then also issues on the ICU for the patient. So that's why we use, in every particular case, we use this NIRS. Also, we do a lot of groin cannulation, so that's also interesting to have these on board. As mentioned, also this is an article from Randolph Chitwood. As mentioned, we do a lot of groin cannulation, but be aware of the shape of the aorta. If it's quite thick and calcified, we go for another cannula of cannulation site. Assisted venous drainage, also very important, or kinetic or vacuum. Be aware of using vacuum with centrifugal pump. Then you can draw air out of your oxy. But also be aware of that if you have bad of assisted venous drainage, it's not a solution for improper cannula positioning. So that's why we use in every case TE also for a good cannula positioning. It's better for you as a perfuser, but also for the surgeon if it's well positioned. So do not use assisted venous drainage as a solution. If it's insufficient, it's a proper cannula positioning, but still insufficient, then you can use or vacuum or assisted venous drainage. And we use the kinetic, so we use an extra centrifugal pump in the venous line. Especially in this particular case, this is an endoscopic or thoracoscopic AVR. When the approach is from the right side, you see if you don't have a good drainage, the right atrium will block the surgeon's view. So that's quite important. We use a hybrid system for that one. As mentioned, below the reservoir, You have then the EVO, venting blood goes inside the reservoir, goes through the EVO, which you can put on percentages to have that steady state and to have a really good, steady drainage. For the pump, we use centrifugal pump, which is the main driving force of our MiEC system. Also for venting the aortic needle, it's all been done by the centrifugal pump. As mentioned also before, for the safeties, link it to a ramp down function and excessive negative pressure or another regulation function, but I also explained it this previous. Cardioplegia technique or myocardial protective strategies. We use our own cardioplegia and intracellular solution. We give one single shot, so it's easy for the surgeon as an endoscopic approach, one single shot, and it can go up to 2 hours, and we dilute the patient with 300 mils, so it's also easy to to put inside a MiEC system. Also for the dilution part, we do a retrograde autologous priming. So we start by de-airing the system with crystalloid, and then afterwards we prime again with the patient's blood, as mentioned here. So you see a tubing clamp on the post-oxygenator, the outlet, and then there is a line which goes to the cell saver. And also the entrocate autologous priming. In this particular case, what we do is we start going on bypass with a closed clamp. So all the crystalloid priming we push to the cell saver. And this is all dependent on the volume state of the patient. If everything is been pushed or the volume state or the pressure is low, we open the arterial clamp and then you go on bypass. Also important is training and education. What we did here in our center, we sat together with the surgeon, asking what he needs to do this minimal invasive approach, and then we built the system around that, and that's how we came to our final design, which I showed you at the beginning of this presentation. So it is important for all the stakeholders that they are aware what to do. It's a team approach. There is a bleeding or so on, it needs to be dealt with that, and also do not give as much volume as say if the anesthesiologist dilute the patient with 2 liters advance, you lose your beneficial effect. And as mentioned also, it is a MiEC strategy, so it's not only the system, you're forced using a certain strategy using the system, and I think the strategy that works. Also the safety mechanisms I showed you, if you have those safety mechanisms inside your system, then it can be as safe as a conventional when using the proper safety mechanisms. So the combination mix and MiEC is possible. You have some ground rules, you have some safety mechanisms, but be aware that all the stakeholders look in the same direction and you know the critical parts of the surgery. So thank you for your attention and I wish you a pleasant afternoon. Thank
you. So this was a very interesting session. Are there any questions from the audience? If none, is there any question from the panel?
Some comments maybe.
I don't have too much experience with MiECTiS, to be honest. We have one surgeon who does it at our institution, and we don't use MiEC with him. It was interesting, actually, what you said in your presentation, that you've had success with venous drainage unconventional, and then it was also successful in MiEC. And we struggle a little bit with our venous drainage in these mixed cases, so I'm not confident that trying MiEC would help very much.
So, Dr. Malvini, do you have any questions?
Good morning. Hello. How are you? So I saw the session was fantastic, really. Compliments to all of you. So I'm very happy because you provide very, very clear messages. I want to do some small comments, if you agree. So the first one that, I mean, I do agree, completely agree. is that we have to change, probably from your words, from your presentation, I can say that we are in the process of changing the idea of the minimal invasive cardiac surgery. I mean, doing operations that are long, maybe demanding through a small cut is not minimal invasive, at least for us in Ancona. We apply the same principle that I saw from Professor Gonaidin's presentation. So the other very important aspect, if you want to provide a reduced trauma to the patient, teamwork is essential. This was the second key words from your presentation. That is very important. And the integrated approach, such as the ERAS protocols that finally are coming up also in the cardiac surgery fields, are really promising. And probably this is the pathway that needs to be followed if you want to improve patient experience and the outcomes. I mean, the usual hard endpoints is mortality, cerebral stroke. These are the basis. I mean, patients expect to come back home. And so we need to work on the rest just to make smooth for the postoperative period. And finally, the last comment regards the older patient. Yes, we are treating older and frail patients. In our center, we are open to transcatheter procedure. I mean, we don't believe they are in competition. There are good solutions also, TAVI or transcatheter mitral for some selected patients. So there is no way. There are some of these patients definitely will benefit for a non-surgical option, but maybe better interventional option. The other point is on the younger side. I mean, we are treating also young patients now. There was some changes also in the guidelines. Some of these patients are thinking about mitral valve patients. Maybe they are mildly symptomatic. They are very active. So for this patient, operation, having cardiac surgery is a terrible condition. I mean, it's probably they think the disease, the cardiac operation. So having such an integrated approach, I mean, you can do an operation, surgeon can minimize the trauma, so providing small incision, the small anesthesia from the anesthetist, aggressive pain control, optimize extracorporeal circulation. When you can do MiECT, we don't do the MiECT for the mitral, for example, but we try to keep our operative times low. I mean, avoiding hemodilution. I told you yesterday, I know that blood cardioplegia maybe is the best, but we like to use now the nidocardioplegia. For us, it works, for example. These are all changes that you can achieve through really the teamwork. When I say teamwork, it means also from the research side. So we are very happy we got all our clinical perfusionists. They are really involved in all the aspects of the process in the treatment of the patient. They're just not delivering a technical action, but there is discussion. So every day, I'm happy we can learn also a lot from them and from the anesthetist. So I was very happy. I mean, it was a fantastic session, really. There's clear messages. This is a modern way to think about cardiac surgery.
So thank you very much for the comment. I think we should move on to the next session. Thank you.
Thank you.
Good morning, everybody. So we will start. Sorry? Okay. Okay. Good morning, everybody. We're going to start on that very interesting session now with I'm really looking forward to all this experienced speaker. And the first of them, I'd like to announce Dr. El Shafi. He will talk about the optimal circuit in all age and comorbidities. Please go ahead.
Thank you very much. It is a delight to be here as always and to share a vision. I've taken the liberty of changing the title, but not the topic. So I'm speaking about MiECTiS 2024, a decade of experiences, as we are celebrating a decade of this existence of the society. So I'll try not only to elaborate MiECT for which patient, and is it something for a selected patient group or for all patients, but also into the history of the society and about a lot of things that we did right and a few things that we retrospectively could consider some mistakes that we have done. When we sorry. If you look at ERAS, we find that the idea of ERAS, enhanced recovery after surgery, is quite similar to MiECT. It is defined by perspective, enhanced recovery. It's a strategy rather than a single treatment component, and it is a holistic approach towards enhancing physiologic reserves in order to improve outcomes. When we introduced MiECT at the beginning as a concept, we said it's a strategy rather than a machine, and we were heavily criticized because we are told that we are complicating things. We want to spread the message. We want to get the people into the boat, and by calling it a philosophy and a strategy, we are creating some kind of reluctance to adapt the technology. And we were asked, okay, which component of your MiECT system is the important one? Should I leave out the reservoir? Should I leave out the cardiotomy suction? Do I have to do everything at once? And yes, we do have to do everything at once because everything adds to it. And when you come to something like ERAS, nobody questions, is nutritive support important? Is prehabilitation important? Is pain management important? It's all one package with one goal. And MiECT, the goal is a holistic approach towards respecting physiology with preservation of homeostasis as its cornerstone. So actually, we're going into modular systems, we're going into personalized medicine, but however, this all has to have a strategic framework in order not to create chaos. And we try to implement this classification system just to give the readers and the users a way of finding themselves in the world of MiECT. Are we using a type 2 system? Are we using a type 3 system? How do I compare different results from different groups? Could that be related to the type of system that they're using? And one of the problems that we have with this classification, it is an evolutional classification, but it's not a chronologic one. We jumped from type 2 to type 4 before MiECT was even introduced as a terminology. We thought at that time point that it was minimal invasive, and actually I had a presentation at EACTS in 2010, 2011, where I introduced the mini machine as a minimal invasive concept. And one of the problems we're facing is this nomenclature of type 4. What is a type 4 system? A type 4 system is nothing else than a type 3 system, which gives you the option of introducing a reservoir. And the one thing, there have been two groups that have been very active in type 4 modular systems. That's the group of Professor Nasiadis here in Thessaloniki and the group in Braunschweig with my former head of staff, Wolfgang Haringer. And we only made the difference in subclassifying type 4 system either into hybrid system, where you have a reservoir in place, you bypass the reservoir and you just have to open clamps if you're in time of need, or a system where you have quick connectors and in time of need, you can integrate a reservoir into the system. But most of the time, or most of the surgeries are performed with a type 3 system. So it's a reservoir optional system. This is a study from the state of Michigan in 2006 to 2010. They had what they called POCMA, a phase of care mortality analysis. It was a quality improvement tool, and they looked in the state of Michigan over this time period with over 53,000 cases done at causes of death, and they tried to look retrospectively, if we analyze mortality, in which phase of patient care could we have done a difference? And we see that 35% of cases, when they analyzed them, they thought they could have done something else in patient selection or timing of surgery. That gives us a window of opportunity, but as this means that either we have to give the patient another treatment option, a TAVI, a mitra clip, or we have to improve in our surgical performance. And we're mainly focusing on non-modifiable variables. And one of the non-modifiable variables with which we are confronted is patient age. And the idea of respecting physiology and respecting homeostasis is we're preserving physiologic reserves. And these reserves are what the patient needs to overcome the additional burden of surgery. And it's obvious that patients with a good physiological reserves, young patients, low-risk patients, they experience low morbidity, low mortality because they have these reserves. So the patients of interest that we're focusing on to show an impact of preserving physiology and homeostasis are actually those with depleted reserves, and which are better patients for this group analysis than octogenarians. So we have a large, over the years, we have a large database of patients with which we have implemented MiECTiS, and we had a look at our octogenarians in which we compared propensity score match 126 patients in each group. Their average age was about 84 years. They had a high Euro score, and we saw that in this patient collective, after propensity score matching, we had a significant difference in 30-day mortality. It dropped from 9.5% to 2.4%. And we saw that we had a significant difference or a significant reduction in post-operative low cardiac output. Again, when we went into more complex surgery, we found that we had 52 patients in two groups, which were again propensity score matched, combined AVR plus CABG. And we saw that the numbers needed to treat are a bit more, although these are lower number of patients, but with mortality differences did not strike significance before 90 days. But this is reasonable. Patients, octogenarians need more time for rehabilitation, and we will experience mortalities beyond 30 days. And at 90 days, we had statistical difference in mortality between both groups. So is it only an age problem? Or are there other patient collectives that are similarly at high risk? And then we said that patients in end-stage renal disease, patients on dialysis, are a very important patient cohort. Why are they important? Because their numbers are on the rise. Momentarily in Germany, we have about 100,000 patients on dialysis. The numbers are expected to rise by 20 to 25% by the year 2040. And we know that these patients are high-risk patient population with mortality rates, post-operative mortality rates, 30-day mortality rates that are 3 to 4 folds higher than the normal population. This is a publication from Leipzig, one of the biggest centers for cardiac surgery in Germany. And we see that publishing their results in cardiac surgery in patients on dialysis, they had mortality rates of 15% overall, in a population with a Euro score of 8%. But when we go into more complex surgeries, these mortality rates rise even to 30%. So we looked at retrospectively again at our patient population, and we found that between 2006 and 2016, we had operated on 146 dialysis patients. We excluded OPCAPs, reoperations, and MIECTiS. So we ended up with 60 patients in which we could do a propensity score matching, and we found that there was a high incidence of urgent and emergent procedures amounting to over 50% in the population who had logistic euro scores which were beyond 14. And the patients were long on dialysis, much longer than most other published data in that field, and over 30% had combined procedures. And we found that their mortality rate of the overall population was 22%. When we looked at the differences between conventional systems and MiEC, that dropped by over a third, 2/3 actually. And that was statistically significant. And we're speaking about 30-day mortalities. And again, low cardiac output was significantly lower in the MiEC group. When we looked at transfusion rates, we didn't find differences. Why didn't we find differences? In octogenarians, we find differences. But we learned that even octogenarians do not need liberal transfusion strategies. This is something that we have never introduced to dialysis-dependent patients. So we have a liberal transfusion strategy in dialysis-dependent patients. And we looked at the intraoperative data and we found we had significant difference intraoperatively. But once they went to ICU, and I was head of the ICU, so that was my management, I couldn't blame anyone else, we adopted a liberal transfusion strategy and the difference was gone. And most studies that have been performed comparing MiEC to conventional systems that failed to show differences in transfusion either had too low patient numbers or adopted liberal transfusion strategies. All other studies showed significant differences in transfusion. So is it only a solution for high-risk patients? Yes, if we're aiming at mortalities, we have to look at patients with high mortalities. But we cannot ignore that one of the another problem in cardiac surgery is that we have a high rate of morbidities. And if you look at the STS database, and these are data published from 2021, we find that in combined procedures, mitral valve replacement with CABG, we have a major morbidity incidence of 35%. So this gives us another window of opportunity, an opportunity to improve outcomes by reducing adverse events. Again, through preservation of physiologic reserves, respecting physiology, and preserving homeostasis. And this is, COMEX trial has not been published yet, so this is to date the largest prospective randomized trial ever conducted between MiEC and conventional systems. We had published that in 2011, and it was a type 4 system, and it involved 6 centers in Europe, 3 in Germany, 3 outside Germany, 250 patients roughly in each group, simple first-time CABG, AVR, or CABG and AV plus AVR, and these are only the results from Braunschweig. We're the largest center with the highest experience in MiEC, and we had about 80 patients in each group. And one of the things that interested me most is in how many patients do I achieve an optimum outcome? An optimum outcome was defined as no complications and no additional risk through transfusion. We can argue a lot about the drawbacks of transfusion, the negative impact of transfusion on 30-day, on long-term, but something that we all have to agree upon, transfusion is a risk, and I don't want to subject my patient to a risk, and I cannot subject my patient to a risk and call it an optimum outcome. So when you look at how often we achieved this optimum outcome, it was 70% in the MiEC cases and 52% in conventional systems, with a significant difference. And if you look at the subgroup analysis just in Braunschweig, you will find that combined procedures, we had more combined procedures, 14% versus 6% in the MiEC group, meaning that MiEC had the capacity to even overcome the additional morbidity of combined procedures. We had statistically significant differences in transfusion requirement, but in low-risk patients, but we had transfusion triggers and all were accounted for the whole, all centers. We had a difference in transfusion rate and in transfusion volume, and we analyzed all that. And in addition, we had significant differences in the incidence of atrial fibrillation. We cut down atrial fibrillation by 30%. And even subsequent multi-center meta-analyses have all come up with these 30% reduction in postoperative atrial fibrillation. And if we look at in the multivariate analysis at the predictors of this atrial fibrillation, the only modifiable factor was the type of machine used. We can't change the age of the patient or the procedure. And the key to this all is the longevity of extracorporeal circulation. The main difference between minimal invasive from an anatomical perspective and a physiological perspective is with the factor time. The longer that we are on MiECT, the more evident the benefit of MiECT is. For minimal access, this is not true. And we did an analysis in which we looked at roughly 800 patients, elective first-time CABG, who came to the hospital in sinus rhythm. And we looked at the incidence of discharge with atrial fibrillation. So it's not atrial fibrillation within the first 2-3 days and it went away, but we discharged the patients to rehab with atrial fibrillation. And it was significantly less with the MiECT group. And we have the advantage in Germany that all these patients go to the rehab centers. So most 90% of these 700 patients had a Holter monitor within the first 30 postoperative days. And again, the incidence at 30 days was lower in the MiECT group. And if we looked at the predictors of this postoperative atrial fibrillation in the multivariate analysis, the type of circuit played a role and the time on extracorporeal circulation, but only for conventional systems. For the MiECT system, the time on machine did not play a role. I need 2 more minutes and then I'll conclude. One of the problems that we're having in the society is how are we selling our results? We definitely have a marketing problem. As surgeons, we're not convinced that we need to do marketing. However, if we try to propagate a philosophy, and we're struggling with that for over this decade, we have to realize that we have a problem. And one of the problems is that we've frequently, and at the beginning of this, introducing this philosophy, we saw it as an alternative to OPCAP. This resulted that even in the largest meta-analysis ever done comparing conventional systems to MiECT to OPCAP, they found that the MiECT system was superior to OPCAP in 5 different variables. But they concluded at the end that MiECT may represent an attractive compromise between OPCAP and conventional systems. So I'm superior, but I'm a compromise. How come? Excellence should be self-driven. We want an optimum outcome for our patient, but we in cardiac surgery are always driven by competition. It is the cardiologists that are improving the results, and then we decide we have to match them. No, we have to improve our quality by our own. So where lies the future of MiECT and the future of cardiac surgery? I hope in an optimum outcome, and I hope through precision medicine, through individualized solutions, through modular systems, we can achieve that. Thank you very much.
Thank you, Afra, for this excellent talk, and congratulations for these results. There's a question from the audience, or if not, I have a short question to you. As I know you always use this RockSafe system from Terumo. Did you make any modification over the years, or did you continue with?
No, actually, we started, our first MiECT system was the one with Cardiothoracic, which Mike mentioned yesterday. It looks like an infusion pump. And this was actually a type 2 system. They had issues with patents for their machine, and they left the market. So one of our perfusionists, Uwe Schönrock, went to Terumo and developed their own MiECT system, and it was a type 4 system from the start, because we could influence directly the introduction of the system and the evolution of the system. So we said we want a modular system with which has components with which we can do valve surgery and which has a safety net, so that we can say, do the system, and if you face any problems, introduce a reservoir, and you're out. We hope that that would help us in propagating the system outside our hospital, because we didn't need the reservoir so often. And so we started directly with the type 4 system.
Now, to announce the next speaker will be Dr. Popov. He will talk about the comorbidities in MiECT patients. Dr. Popov, please. The floor is yours.
Dear colleagues, thank you for the opportunity to present our experience in MiECT system. It's a great privilege for me. So in recent decades, there has been a trend towards a decrease in mobility during cardiac surgery. However, complications can still develop, leading to long persistent multi-organ failure, which in many cases is associated not only with the surgery itself, but also with the initial morbid status of patient. In condition where conventional CPB remains the routine method for cardiac surgery, the roles of complication in comorbid patient increased significantly. This is due to a whole complex of damaging factors accompanying CPB. Triggers the SIRS, ischemic reperfusion syndrome, blood area contact, and temperature shift in various patients of extracorporeal circuit. This is in turn the accompanying by damaging to end organ and organ failure, which significantly aggravates the initial comorbid status, transforming chronic organ dysfunction into acute and sometimes irreversible. So, which significantly we define a patient in high risk if he has more than 5 points of a Euroscore and more than 5 points on the Charlson Comorbidity Index. At least 40% of patients undergoing cardiac surgery are high-risk patients with severe comorbidities. This is our real patients now. Cardiac surgery is now dealing with high-risk patients, and it is forced to compete with endovascular therapy and needs a significant reduction of invasiveness. One of the central positions of my opinion belongs to more physiological perfusion. This use of MiECT circuit seems very encouraging. Meta-analysis show clear advantages of MiECT compared with conventional CPB by reducing 30-day mortality, including complications such as stroke, MI, and renal dysfunction. The advantage of MiECT many times discussed yesterday and today, and its strong evidence, and this all means approved physiologically. However, the diversity of MiECT system and the heterogeneity of patients and outcomes don't allow us to confidently extrapolate this data to age-related comorbid patients. However, the patients' benefit of minimally invasive technologies highlight the needs to explore the potential of MiECT to improve outcomes. Here is a story of our effort on MiECT penetration. We have implemented MiECT since 2011, but real progress has begun since 2019. Then we are starting to collaborate with Thessaloniki team and Professor Anastasiadis and MiECTiS Society. For now, we are using type 3 adjusted extracorporeal circuit. Primary is about 750 milliliters. For reason of our patient safety, it was possible to switch to a type 4 circuit with the inclusion of a hard shell reservoir. The aim of our study is to compare the clinical results as well as the severity of systemic inflammatory response in a comorbid patient who underwent cardiac surgery under conventional CPB and the MiECT system. A retrospective cohort study carried out as a part of our research of our center work and included 760 patients. Inclusion criteria was comorbid status, CPB time more than 90 minutes. Exclusion criteria was emergency surgery. According to the extracorporeal circulation method, 2 study groups were formed with a conventional circuit and the minimal invasive circuit. After the initial review of medical records, 68 patients met the inclusion criteria. Propensity score matching was carried out. After that, the 6 patients were excluded. To analyze the method of extracorporeal circulation in high-risk patients, the following indicators were studied at 2 control groups. Initially before the start of cardiopulmonary bypass and 24 hours after surgery. We assessed lactate level, creatinine level, oxygenator index, level of hemoglobin based on 3 hemoglobin. Checkpoints of markers of systematic inflammatory response, interleukin-6, interleukin-10, procalcitonin, STRM1 was at 1 hour after start of CPB and at 24 hours after its completion. We assessed clinical data such as respiratory and renal complication, drainage blood loss in the postoperative period, disorders of hemostatic system requiring correction and blood transfusion, the needs of sympathomimetics, length of stay in the intensive care unit and in the hospital. A comparative analysis of patient baseline characteristics did not reveal statistically significant differences. The same results you can see regarding risk assessment. When comparing the type of surgical procedure, there were no significant differences between 2 groups. The group were also comparable in the main parameters of perfusion, duration of bypass, cross-clamping time, volume of blood loss. Postoperative blood loss did not differ significantly between the study of group. Significantly higher doses of inotropic and vasoconstrictor support were observed in the conventional group, with the most pronounced differences recorded then noradrenaline was used. Intergroup comparison of diuresis rates demonstrates significant differences with comparable doses of furosemide stimulation. Pulmonary injury assessed by oxygenation index occurred less frequently in the MiECTiS group. Creatinine as a marker of renal damage did not show significant differences between group. The lactate level, which indirectly determines the adequacy of oxygen delivery consumption balance, was significantly low in the MiECTiS group. The level of free hemoglobin indicated hemolysis was significantly high in the comparison group. Pro-inflammatory interleukin-6 was significantly high compared to baseline values in both groups. Pro-inflammatory interleukin-6 was significantly higher comparable to baseline value in both groups. Intergroup comparison showed 2 differences at 2 control points for the indicator. In turn, anti-inflammatory interleukin-10 decreased significantly by 2nd control point in the conventional group, while in MiECTiS group, its values did not change. Intergroup comparison to interleukin-10 levels also demonstrates a significant difference at 24 hours after CPB. The level of leukocytes, C-reactive proteins, procalcitonin and STRM were significantly higher than the initial values in the control group. In the MiECTiS group, only procalcitonin levels changes significantly. At the same time, and intergroup differences at 24 hours after surgery was observed in the levels of leukocytes and STRM1. The needs for end organ support did not differ significantly between groups. In the MiECT group, there was a shorter duration of mechanical ventilation, shorter length of stay of intensive care unit, and shorter length of sorry. The need for end organ support dialysis on the ECMO did not differ significantly between groups. On the MiECT group, there was not shorter duration of mechanical ventilation, shorter length of stay of intensive care unit, and shorter length of hospital stay. Comparison of hospital mortality demonstrate no difference. So, in conclusion, discussion, the most significant intergroup difference in the frequency of symptomatics were observed in noradrenaline used to relieve vasoplegia and maintain adequate mean arterial pressure. Indirectly, this may indicate a greater severity of a SIRS in hospital in control group. The statistically significant difference in lactate level likely indicate more adequate oxygen delivery in the MiECT group. The use of MiECT is associated with shorter duration of mechanical ventilation, length of stay in ICU and in the hospital. The dynamics of increase in interleukin-6, leukocytes, and estrem indicate more pronounced manifestation of systemic inflammatory response using conventional CPB. The decrease in interleukin-10 after 24 hours in the CPB group indicate immune suppression, which was not observed in the MiECT group. CPB patients with systemic inflammatory response and immune suppression, which together determines a high risk of multi-organ failure. So, limitation of the study. Thank you for your attention.
Thank you very much, Mr. Popov, for this very interesting lecture. It seems to be a very interesting roundtable, this one, ladies and gentlemen, talking about MiECT in clinical practice. But we have to move forward to the next presentation. Thank you very much. And this is a very interesting topic that Mr. Condello is going to talk to us about. How can the MiECT be applied in patients undergoing minimally invasive mitral valve surgery? Mr. Condello is a chief perfusionist from the Bari University Hospital of Italy.
Thank you so much, everybody. It's a great pleasure for me to introduce this presentation. I am very proud to share this innovative way, is an innovative concept that I think that in the future will improve our clinical practice. It's a really simple application of tips and tricks to improve the problem that we have today about Gauss's microembolic activity for endocavitary suction. In particular about minimal invasive cardiac surgery for mitral valve repair. And in this context, the state of art in intracardiac suction for mitral valve surgery was conditioned about the use of SAMP aspirators. No, we know all this system. No. Nevertheless, the positioning of these aspirators is in the upper left pulmonary vein or right pulmonary vein, and depends on the typology of a surgery. In this context, we observe that the problem and the main limitation are about the increase of delivery of gaseous microembolic activity, the increase of carbon dioxide, and the increase of hemolysis through the use of these aspirators. Is not a good option for the use of MiECT with artificial venous reservoir. Is not a good MiECT, is not a MiECT, the use of this system. The main implications are about in goal direct perfusion, because increase the carbon dioxide outside the oxygenator. the increase of microembolic activity. We know all the deleterious effects of ischemia in the microcirculation and the damage from reperfusion. And if we use venting on pulmonary artery to prevent this, the 63% of patients that have effective drainage of the right section on the pulmonary artery have a return of oxygenated blood from the pulmonary veins during the cross-clamp time. Is important issue because most people say that if I have a good drainage from right cavity or put the venting in a pulmonary artery, I resolve the problem in the pulmonary vein. This is an important issue for the closed circuit and for extracorporeal membrane oxygenation. Today we have a problem of venting. The minimal invasive approach, I think, that improve with the extremization or maximization of biological impact all procedures that involve the circulatory support. The vision and perspective is a correlation of minimal invasive cardiac surgery with mitral valve repair or substitution with minimal invasive extracorporeal circulation. With intracardiac suction without bubbles. This is an example. No, you see that. This is the two vent, one in aortic root and the other in pulmonary vein. How it is possible? We use, in our experience, this cannula that is a retrograde cannula for cardioplegia. We put this inside the venous pulmonary vein, and we use many tests, dry tests, to assess the use of it. We start with the heart of pig to improve the isolation of pulmonary vein, and we try to simulate this in vitro. This is our circuit. This is the two pulmonary vein we put inside the small tubing. We use a manual insufflation inside the balloon in the first of all, in the seconds. Okay. We create a venous reservoir with liquids in continuity with our MiEC. Okay. We control the pressure. And we start with the aspirators of the liquids from the venous reservoir. In this context, it is a pulmonary venous return. We open the venting line in continuity with our bubble trap without extracavitary cardiotomy, increase the RPM, and we observe that there is a very beautiful effective suction. So, we start in this context, and now we are in semi-final for ISMIX. We just arrived before 3 prize for innovative idea with low cost to improve our clinical practice. The limitation of this cannula is the shape, the small cannula diameter, and the potential visual clutter on the surgical field. For this reason, we developed a patent to improve the design of this system, to become really feasible, to improve our clinical practice in all surgery, not only on MiEC, because today we have a mitral valve repair with conventional extracorporeal circulation in mix. Yes, okay. But the aspirators of SAMP is really pro-inflammatory, pro-embolic. This is a system that I think that improve all surgery. The system is this one. We idealize with my head of cardiac surgery. This approach is really simple. We use a 1 balloon, 2 balloon, 3 balloon, or 4 balloon inside the pulmonary vein. It's possible to use 1, 2, 3, or 4 in relation to the visual. And the system is a composite device that have a disposable and a monitoring system. And The only problem of this idea is an implantable device and is a class 3 for normative of MDR, medical device regulatory. Nevertheless, it's really important that today I share our preliminary report with this possible that we have all about retrograde cardioplegia to improve the management of the mix procedure. And I concluded my presentation. I not explain more details about this presentation because we have a competition for ISMIX that we have on 30 May. And I presented the full work in Athens the next 20 days. Thank you so much for your attention.
Thank you very much, Ignacio. That was a very interesting and a very impressive presentation. It looked a little bit complicated for me, but Mrs. Jansa from Toronto would like to comment and ask you a question.
That was a great presentation. I think it really focuses on an area that is a big topic of contention when we're trying to do minimally invasive with MiECTiS. I was just wondering if you guys had done any research into what kind of flows you're actually getting through this venting mechanism, given the fact that it is just gravity or draining directly through the pump.
Is a good thing. In our perspective, this approach is for all typology of aspiration with roller pump, with passive drainage, with Venturi effects, or for the use of inside the inlet of the pump. Is important the monitoring of negative pressure inside this needle to assess and regulate the suction. We think all, I start with this society that I have 24 years old, and the perfusion is my mission, and it becomes that these items is the principal limitation for the company, no? The company develop devices such as the hybrid reserve, but today we focus on the cannula, on the endocavitary aspirator. So this is my perspective, but I think that all perspectives are really useful to improve MiECTiS to extend in all procedure. That the first of all limitation is the bleeding, the blood loss. If together with the company develop a system to do it, we extend really MiECTiS.
Thank you.
You're welcome.
Thank you very much. We have to move forward to the next presentation.
Okay.
Thanks a lot.
Thank you. Thank you, everybody.
I will grab the opportunity to thank and express my gratefulness to Professor Anastasiadis once more for this kind invitation. And we have to move to the next presentation, to the next presentant, Professor Mr. Kimura, a distinguished cardiovascular surgeon from Saitama University of Japan. And he will share with us his experience with minimized perfusion strategy and circuit for open thoracic aortic repair.
Thank you so much. First of all, I'd like to thank Dr. Anastasia and organizing committee to give me this opportunity to talk about our data at this special 10th year anniversary meeting. And today I'd like to talk about the experience of our minimized perfusion circuit for open thoracic aortic surgery. No disclosure. First, let me introduce our hospital. Our hospital is located in Saitama. Saitama is located in the north of Tokyo. And the population of Saitama Prefecture is 7.3 million. Our hospital was established in 1990 and one of the 3 university hospitals in Saitama Prefecture. We are now covering about 2 million people around our hospital. We are doing about 120 cases of open thoracic aortic surgery annually, including 50 cases of aortic dissection surgery. Next, I'd like to talk about our ECC system. As you know, use of conventional ECC with open circuit can cause biological reaction, including inflammations, activation of coagulation cascade, and hemodilutions. An ECC using a closed circuit attenuates such biological reactions However, minimized ECC has not been widely used in our daily practice. Since 1998, we have routinely used a semi-closed bypass circuit, incorporating a closed circuit. We call this system as Modified Minimized Perfusion Circuit, MPC. Now we are using this circuit in all cardiovascular surgery, including minimally invasive valve surgery. This slide shows the core component of the MPC. There are two roller pumps, a closed-loop tubing system, an oxygenator, a venous de-airing unit, and heart cell reservoir. Venous blood circulates in the closed circuit. The main pump regulates the bypass flow. Blood from the venting tube and cardiotomy suction drain into the reservoir. The reservoir is connected to the venous line. Air bubbles are automatically captured in an air trap, and these bubbles are sent to the reservoir through the air sensor and the air removal. Priming volume is our system is 700. This slide shows one of the key features of our system, reservoir level control sensor. The level controller detects change in the fluid level and automatically regulates the speed of volume control pump to stabilize the circulating blood volume. This system is useful in stabilized volume control during ECC. In case of aortic arch repair, a selective anti-leg cerebral perfusion line is connected to the main arterial line. So this video shows automatic regulation of fluid level in the reservoir. Blood in the reservoir does not fall below the set fluid level. This system also protects air bubble entering the main circuit. We uploaded this video to YouTube. Our system is different from the type 4 MiECTiS circuit. For example, we are using a semi-closed circuit and rotary pump. But our system, our circuit shares many other features of MiECTiS, including low priming volume. Our standard technical cabbage is now off pump, but we started using MiECTiS, I think type 2 circuit, including the centrifugal pump for limited case of the cabbage recently. Many studies have reported the benefit and the favorable outcome of MiECTiS in cabbage or valve surgery. In 2013, Momin reported the feasibility and safety of minimized cardiopulmonary bypass in major aortic surgery. However, utility of minimized perfusion circuit in thoracic aortic surgery remain to be elucidated. So we publish our data regarding the use of in aortic repair for type A dissection surgery, type A dissections. I'd like to show you some result of this paper. Between 2000 and 2019, a total 706 surgeries were performed in patients with type A dissections using this system. Based on the distal extent of aortic repair, patients were divided into the hemiarch group and arch repair group. Then transfusion volume outcome were investigated in both groups. This slide shows the operative technique. ECC was established by arterial cannulations through the ascending aorta, femoral artery, or axillary artery. Distal anastomosis was performed under circulatory arrest with moderate hypothermia. Brain protection was achieved by anterograde cerebral perfusions. in case of arch repair. A cell-saving device was used for pre or post-ECC bleeding. This slide shows characteristics of total patient and patient in the hemiarch group and arch repair group. 26% of total patient had preoperative shock, and 35% of total patient suffer from organ malperfusions. This slide shows operative variable. In this series, no patient required conversion to conventional ECC, and there was no complication related to the use of the MPC. This slide shows the early outcome. The 30 days mortality of total patient was 6%, and 30 days mortality of hemiarch repair group and arch repair group were 5% and 12% respectively. Stroke rate was 6% for hemiarch group and 8% for arch repair group. This slide shows prevalence of transfusion therapy. In this series, 92% of total patients underwent blood transfusions, and the prevalence was increased in the arch repair group. The median total transfusion volume was 680 milliliter for hemiarch group and 1970 milliliter in arch repair group. As I show you, in emergency surgery, transfusion requirement remain high even in use of MPC. Next, we investigate the transfusion requirement in elective aortic arch repair. In this study, we investigate the outcome of 351 patients who underwent elective arch repair. The etiology of thoracic aortic pathology include non-dissecting aortic aneurysm and chronic dissections. The average age was 73 years. Regarding the operative technique, frozen elephant trunk was used in 90% of patients. The median operation time was 389 minutes, and the use of cell-saving device was 26%, and 38% of patients received no red blood cell transfusions. The overall 30 days mortality and stroke rate was 0.6% and 6.6% respectively. So this is my final slide, and in conclusion, we consider the use of the MPC in thoracic aortic surgery appear to be safe and clinically feasible. However, non-red blood cell transfusion rate was 35% in elective aortic repair, even with the use of the MPC. The transfusion requirement remain high for patients undergoing aortic arch repair. We think our future multi-center study, which investigates the utility of MPC against conventional ECC, will be needed. Thank you for your attention.
Arigatou gozaimasu, Professor. Thank you very much for the very interesting presentation. Please take your seat, and now Mr. Zenig will ask the discussants to make a comment, a quick comment, please.
Thank you very much for this interesting presentation, Professor Kimura. I have a short question. Your system, I think it grew up with you, and if I would come to you and to buy and to learn the system, how long will it take for me? Is it learnable? Is it teachable, this system, or is it isolated for your clinic? Because it sounds really interesting to have a system like that.
So in terms of the perfusionist, okay. We develop our own simulation device of this system. And then before, many young perfusionists learn how to handle our circuit using such a simulation system. That seems very nice. And young surgeon also learns how to handle our system using the simulation device. That seems very good thing for surgeons. to understand the principle of our minimized perfusion circuit, I think.
Mr. Hayek and Mr. Tsuki, do you have some comments to make? Where are they? Commentators, they are not here. Oh, sorry. Sorry for that. Please.
Congratulations, it's fantastic results. I'm fascinated. We never used mini system for this. You say you use only moderate hypothermia, no deep hypothermia, circulatory arrest.
So so in case of aortic repair for the hemiarch repair and arch repair, so we need to use distal circulatory arrest technique. So at the time of the distal anastomosis, so the reason why we need to lower the temperature. But we use moderate hypothermia about 22 to 23, yeah, at the rectal temperature.
I have another question, sorry for that. Do you also practice beating heart aortic arch replacement, or do you clamp and you get plagia? I didn't see that on, or perhaps I missed, sorry.
Yeah, but in this series, all surgery was performed under the circulatory arrest. So, in case of the aortic repair of the descending aorta, at that time we can we do the surgery with a partial bypass on beating heart. But in case of the aortic repair of ascending aorta or the aortic arch, we need to lower the temperature.
Thank you very much. There another question from the audience. Otherwise, we have to close this session. And I thank you very much. Oh, from the floor. Thank you.
Thank you very much. Just a quick question for Dr. Kimura and Dr. Condella too. When you are faced, because your circuit looks brilliant also, from what I can understand, but the question is, when you're faced with the right heart surgery, and that includes mix, nowadays what we use is we open the right chest, we don't use any kind of snares, so you are in a different setup than the pulmonary veins. So for Dr. Condella, the question is, would your system, do you think, apply to because, mitral is not alone. Most of the time it's married to the tricuspid, and you have to do something about that. And the same applies to you, Dr. Kimura, when you're faced with the right heart side chambers, simply because the air amount probably is more. Is your system safe enough, you think, to handle this? Thank you.
Thank you so much for your question. I believe that it is more simple manage the bleeding or the venous return from the right heart than the left ventricle surgery. In my configuration, I think that the snare, the vena cava inferior and superior, with bicaval cannulation, I think that is a good compromise to eliminate the bleeding, their air suction from the venous return. I believe that it is more simple manage this aspect for the right cavity than the left cavity. For example, it's more complex the manage of mitral valve, it's more complex the aortic valve replacement. But I believe that proximal paper that I write is tips and tricks to control the bleeding in cavity surgery. There is nothing in literature, and I think that is a good point to start together with the community and the society to improve it. Okay.
Thank you so much for questions. And in our system, so in case of the mix, so the venous cannula are placed in the inferior vena cava through the femoral vein and this SVC, and then that's almost similar with the valve surgery through the median stenotomy. So, and then blood from the cardiac suction directly go to the reservoir connected to the main circuit. So I think very similar. And then we don't have we have no trouble regarding such air bubble.
So I think I will close and thank you very much for this really fruitful session. Thank you very much.